Our vision is providing quality care close to home. January 29th, 2006. Please note this meeting will be video and or audio recorded, and with me included, everybody turn their phones so they don't ring. I don't even know what that is, y'all. That's why if mine goes off, I apologize. I can't get that off my phone, so I don't know what it is.
You have a Samsung or Apple?
Do what?
What kind of phone you have?
I don't know. If it goes off, I'll just turn it off completely. Supposedly I have everything turned off. We'll see. Okay, we're going to call to order. We do have a quorum here. So the next item is, I'd like to ask everybody, I'm not saying speed it along, but we got a lengthy agenda, and we have our risk management report executive session after this. So let's try to move it if we can.
That's right.
If we can't, we can't. Okay, next item is public comment. Do we have any public comment? No public comment. Next item, approval of the minutes from last meeting. Do I have a motion to approve these minutes?
Motion.
I have a second.
Second.
Any discussion? All in favor?
Aye.
All opposed? Next item is mine, customer service. What have we done for customer service?
Well, I like to call it compassionate care.
I know, I understand. I know, I call it customer service. To me, let me tell you the way I feel about that right quick. There is a little bit of distinction, but let's keep it simple. I can't never remember compassionate care. But anyway, go ahead.
Yeah, and what we'll do, even as the managers come up, they may mention some of the things we're doing, but one of the things Duff and I had a conversation. I did talk with Courtney about this, and one of the initiatives we'll probably implement when the individual's coming into the hospital, if they're coming in to be admitted, the Courtney would talk to them at first and say, hey, we have a leadership team. We have some individuals here that we may be, coming and taking care of you. We'll have plant operations director, Craig, come in the room and speak with the patient. Say, hey, I'm Craig Gibson. Anything you need, relating to plant operations. Specifically, I'm the one that you talk with. We'll have the dietary manager come in as well, and then of course Courtney and myself. Usually Courtney and myself, we go down and meet the patients and talk with them, which has been good, to do that, because I had one patient, I went in the room, she was an elderly lady, and she said, Courtney said, "Oh, this is our CEO." She said, "Yeah, he looks like a preacher." I'm like, "Well, I'm a preacher." But the thing is that going in, is customer service not an event? It's a lifestyle, something that we do, and some of the things we want to do not only in the hospital, because we have EMS for at least 2 more months. We want to make sure that we begin to implement customer service in that area as well as the clinics. And so these are 3 pillars of the hospital. You got inpatient, you got the clinics, and you have EMS. And so it's not an event. And so that's what we're telling all our staff. Customer service is not a one-time thing. It's continually. And it's a process. Some areas we hit good and some areas we do not. On a side note, I know I've answered your questions in a long way, but on a side note, I want to just, encourage everybody, to watch the Super Bowl. This couple more weeks, we have a young man named Joshua Farmer from this area will be playing in the Super Bowl. He may be, if he wins, if New England wins, he'll be the first person in Franklin County that have won a Super Bowl.
That's
here. Really?
Wow.
Yeah, let's give him a hand. Come on, Joshua.
Yeah. He has a powerful story. If you go back and just look at his story, both his parents passed away. And he just have a great story, really. And the community has really rallied around him in both Apalachicola and Port St. Joe. So. But anyway, that's my spiel on that. But customer service is not an event, it's a lifestyle. And so we are hoping to implement this other phase of customer service with the hospital.
Can't have, Mr. Bowling, have you visited the rooms?
Yeah, so it's been a while since
I know, I understand, you're busy.
The rooms, but I have gone into the room with David and Courtney and so forth. And
people seem appreciative?
They do. I think folks really, I think they really appreciate that. that extra touch, that just to stop by and say, hey, how are you doing, and anything we can do to help you. And then, I think they do appreciate that. And again, like David said, I mean, it is when you look across, and I've used this at other Alliant facilities as well, what Weems is doing, because I think it's a very important. A lot of times it goes, unrecognized, right, about what focus that leadership, board leadership, executive leadership, departmental leadership, down to the all levels throughout the hospital, about what they do and what they provide every day. And so you guys bringing this forward, consistently recognizing this, and I think it's a great practice. It's a best practice.
I think we need to continue.
You guys
to
do a great
it.
job.
I mean, I can't.
One of the other things too, Duffy, is that, of course, we focus on the inpatient, but the ED is very important too. Really the emergency department. That's something that we'll continue to work on. Of course, I don't go in the ED room as much unless I know somebody that's there.
Right.
And I go in and talk with them. But, from the ED, just from the intake process, every part of the hospital, but it's not only the hospital, you have the clinics, you have EMS, which is very important as well. Because I've gotten calls, even for the EMS. I went out to a family home on my birthday. I was off. They'll talk with them, because of that. And then wind up praying for the family because it was a dire situation. So, it's the three areas. It's just not only the inpatient unit. It's all three areas of the hospital. And we're not there yet, but we're still striving because it's everyday occurrence there. And sometimes we miss it, to be honest with you.
I asked David yesterday, we was going over, or the day before one, looking at the agenda. I said, how's the coffee that we serve? How many people here drink coffee? Y'all drink coffee? You want a good cup of coffee, don't you? You don't want it cold. And I said, do we put half and half with it? How many people would put half and half with theirs? Oh, y'all a bunch of black coffee drinkers. I like half and half. I love half and half. That's a small thing. But people that drink coffee, Bill, you drink coffee? You don't
Espresso.
Espresso? Well, I don't know. Well, I like espresso
A little
too.
cappuccino every
But
once in a
that
while.
seems like a minute thing. But you're there, what, 3 or 4 weeks?
Yeah, well,
Don't
Sweet
you
Bed,
want-
you can be there, yeah.
Don't you want good coffee? I mean, that's a minor thing. And,
Yeah, some of them
But-
like coffee, some of them don't. Some of them
well, that's
drink.
fine. That's good with me. But I'm just saying that if we're gonna have coffee in the morning, if they're allowed to drink it, then the little small things are important to our clients. So, okay. The next item. Any board member got anything? Come on, board members. Are y'all okay with
I'm okay with coffee.
coffee?
I have a question.
Yes.
Say we stock some Celsius.
Are we going to address, go back and address the jaws of life? From last
James.
meeting?
Yeah, we will. We'll get to it. We'll get to
Yeah,
it.
yeah,
Sure.
James,
If you want to, yeah, we
I
need
just
to.
don't want to forget it.
No, don't let me forget, okay?
Well,
Don't
James
let me
gonna have a part of his report. James will have it.
Okay, don't let me, that's good, that's
Yeah.
very important,
Yeah.
absolutely. All right, next item here is, Mr. Hogg, Main Street Rural Health. I believe you have a presentation, correct?
Yes, sir.
Okay, well, come on. This is, cancer treatment, right?
That's right. Be right here.
I can't believe our little hospital's talking about this. Come on, let's.
Good morning, Jeremy. Thank you so much for being here.
Yeah, absolutely. Thanks for having us.
Yeah, just introduce yourself.
Okay, perfect. I'm Jeremy Hogg with Main Street Health. Been working at Main Street for the past 5 years. Been in healthcare for about 20 years, and kind of working across the country and developing new solutions for making healthcare better for everybody.
Is he going through the mic?
Yeah.
I can speak through
Push
the
that
mic for
mic
sure.
up a little bit, we'll make sure everybody can hear this.
Good morning, everybody.
Okay.
Good morning.
Good morning. My name is Dan Parr. I've been at Main Street now for 4 years. I have a long career in healthcare. I used to work at a large academic medical center, overseeing multiple service lines as well. It's a pleasure to be here today.
Thank you so much for being here.
Yeah, so wanted to just take you guys back through the conversations that we've been having and give you a good understanding of kind of what we're talking about and what we're considering to offer here in Franklin County. I think as we look at this, the easiest way to kind of go through it is to talk about what Main Street is. And really what we've been doing for the last 4 years is trying to develop solutions for rural healthcare. When we launched the business, the idea was to try to go back into the places where I'm from, where all the folks, a lot of folks in our business are from, to figure out how we can solve some things along the way. It's not to come in and be a savior of rural healthcare. There's a lot of great things that are happening in rural healthcare. It's just to figure out where we can add value and what we can bring to the table. So when we started the business, we started really working in more primary care than specialty care. As we launched that, it went really well. We expanded over 22 states, working in about 1,300 clinics, and doing a lot of work in primary care. And in that process, we learned a lot about what patients were dealing with in rural communities. And as we started to work with patients, a lot of the feedback that we were getting was, you know, I really appreciate all the help, but I've gotten this terrible diagnosis, and my care to get that diagnosis is an hour and a half away, and I don't have the ability to get there, to do that, to get the help. And so we wanted to try to figure out ways to solve those issues. So we started doing this out in Tennessee, and the first opportunity to do that was in East Tennessee, where essentially we went out and worked with the hospital to develop an oncology program to be able to help some folks that had these issues. And
What town in East Tennessee?
in Dayton, Tennessee.
Okay.
Yep. And so the main thing that we saw first was the folks that were accessing this came from about 3 different buckets of patients that we saw. One bucket was folks that had resources that could be able to jump on a plane, get care wherever they needed to, and it wasn't a problem. The second bucket were asking friends and family to take the day off work and
Right.
drive them back and forth to chemotherapy appointments, and it was a lot on everybody. And the third bucket were folks that didn't have transportation or resources or family, and they were giving up and not getting care. And so we decided that this is where we need to step in and take care of all these pieces, and all 3 buckets really. So we went out and we found the best oncologist we could find to be the quarterback there at the local facility, quarterback in the care, kind of being a general oncologist, if you will. And then we found about 9 or 10 great oncologists that were very specific into their types of oncology. And basically we were letting the general oncologist run the playbook and then phone in these specialists wherever they were needed. And basically we were able to develop world-class cancer care in a rural community where people really needed it, right? We did this in partnership with the hospital to where we put in the investment and didn't ask for any capital from the hospital, and we're able to kind of launch it pretty easily. So that's what we're talking about here, and excited to be able to bring this to a place like Franklin County here in Apalachicola.
How'd that work now? If you got the diagnosis, you need treatment, say in Tallahassee, then the treatment is sometimes what? It's every other day, every day. I mean, then they would refer them to get the treatment.
Yeah.
Is that the way it would work?
Tell them about your 3 days, Jeremy, that they're usually seen in 3 days.
Yeah, the goal is to be able to, once we find out that the patient has cancer, to
Yeah.
be able to see that patient within 3 days and
Oh,
really kind
wow.
of step in. Dan runs more of our clinical operations and
Yeah.
can tell you.
So what my role would be is, once we are implemented and going live, we really build a partnership with the hospital. So we'll be there helping, doing things, et cetera. But the way to answer this question is to think about that journey. Is right now, you're correct, it could be every other day folks are.
Get closer to the mic a little bit.
Yes, sir.
I'm sorry to keep.
No, it's all right. I'll also project more.
Okay.
So the way to think about it is folks are currently driving maybe an hour, 2 hours,
Hour and a half, 2 hours.
an hour and a half,
Yes.
2
Oh,
hours.
it's 2 hours to Tallahassee. If you go at the wrong time, it's terrible.
Right. And, you know, when in doing so, in a very kind of scared mindset.
Sure you are.
So it's not once a week, once a month. Sometimes it's 3 or 4 times. Once you're in those systems, you're also getting your labs done there as well, et cetera. So there's ancillary transportations needed. The concept is have the referring provider stop referring to Tallahassee and start referring here. Help do the infusions here locally. That saves an abundance of travel, headaches, et cetera, and it's possible.
And it's closer to home. And you
How
also-
many other hospital programs do you have currently under?
Yeah,
Your care.
so this is, we'll admit, like, this is new for us too. It's something that we launched about a year and a half ago. And so we've done this all of 3 times, right, in 3 different communities. All of them went pretty similarly, but what we've been able to see is, like, building this in a way where it's actually built underneath the hospital's brand. So not many folks know who Main Street is, and the community can see this as an access point through Weems as opposed to through Main Street. And so that's what we've seen as most successful in those three communities, and what we would plan on doing here.
What's the business model? I mean, what is it that, if I have cancer, how am I gonna get in touch with you or through the hospital? And what do? Do you bring doctors in? Do you periodically? What is the model?
Yeah.
Yes, sir. And I would like to just add on to what Jeremy said. Hearing that this is our fourth, right, could be a little scary. 4 years ago, we said the same thing in the primary care, and now we have over 1,000 across 26 states. So we have confidence that we know what we're doing, and we know there's a need, and we're driven by the mission to solve it. So, do you want me to take that?
Yeah, go ahead.
The business model is simple for us. We make it about the people, the patients, and then we believe the money at scale will follow. On the main thing, the main driver is infusion drugs. So the way that we set it up so that there's no cost to the hospitals is essentially we would pay for the infusion drugs, and then we would get the reimbursement for it. Can I elaborate more on that?
Yeah.
Sure.
Okay. What track should I go down on this? Because we can structure deals, multitude of ways, but the business model is essentially no expense to the hospital. If there are expenses, i.e. the check-in, a nurse, et cetera, we would reimburse those.
But what's the rest of the revenue stream for the hospital?
It's actually the
Ancillary.
opposite. So when we talk about all those ancillary services, the labs,
CTs.
the imaging, all of that, that's happening in Tallahassee. If you already have the ability to provide those services, you would see those.
Yeah.
Ancillary service.
Yeah.
So
look at it
ultrasound,
as-
CTs, labs.
Right. We look at it as continuity of care. Like, this is the place for that to happen. If we're delivering the diagnosis and, the infusion and everything that happens here within the cancer center, then everything else to treat the patient should happen here. And so that continuity of care can be delivered here. And so the halo effect of all of that that's being delivered would be the benefit to you guys.
What's the minimum number of patients you've got to have in this area to be?
Yeah, we've been looking at catchment areas around here to be able to understand, okay, the population is X, the cancer incidence for the population is X. That's what really kind of brought us to this conversation of high cancer incidence, high mortality rates, and then essentially the catchment area that you guys have, not just in Franklin County, but surrounding counties too.
So Gulf County is a higher cancer rate, but we could service Gulf County as well.
That's right.
That's right.
That's right.
Okay, got a question, guys.
Yeah.
Who is the CEO? Are you the CEO with the
I am
company?
not. So CEO is a gentleman named Brad Smith.
Okay, and what are you?
So I run growth for the organization. So looking at the strategy, where we go, how we do it, how we deliver it.
Okay, and you're,
You think of me as like site ops, so I'm in charge of all of the account management, partnerships, everything being delivered.
okay, I just like to know who I'm talking to.
I'm the guy that you'll see early on. He's the guy that you'll have to live with as you
Okay.
start to go into implementation. So.
And how do you work with your oncologists? Are they telehealth,
Yeah.
or anybody on site?
Yes, great question. So we have a full-time oncologist that works for us, right? They will take this site plus a few other sites that we have to be able to, there's not enough volume to support a full-time oncologist, so we'd share them with a couple of sites that we have. And essentially, they would be here once every 4 to 6 weeks on site, right? To see patients, be here. It's the same doctor every time, so they're not talking to multiple doctors on our staff. The other weeks of the month, where they come in, those other 3 to 5 weeks, we basically put up a big screen like this in the clinic room, and they see that same oncologist there on the screen, and so it continues that relationship through. It's just that the doctor's not there on site. So kind of a hybrid model.
Do you need a pharmacist to administer as well?
Yeah, so we'll need a pharmacist to compound the drugs there at the hospital, and so they'll be the point person to be able to put all the pieces together when they get the drugs delivered in, and then we'll have a nurse at the hospital that will train up to be able to deliver the meds.
So you
And who's
could theoretically train, I'm sorry, so you could theoretically train one of our nurses, correct?
That's correct.
That would be a position for them.
And if they spend time doing it, we'll reimburse you guys for the time.
And who's scripting the medications?
Our oncologist.
Your own oncologist?
That's right.
So they go to their own doctor at TMH or wherever they go, and their doctor says, okay, you have a cancer diagnosis. That doctor is not providing a remedy as far as the RX for that?
Yeah, an oncologist, their doctor?
Yeah, I don't know.
Yeah.
Maybe it's a regular doctor, maybe it's an oncologist.
If it's a regular doctor, likely they'd refer those patients into a
Into
place.
a specialist.
Yeah, they'd either tell them where to go or they'd ask them where they want to go. And our hope is that.
And are you getting those referrals directly?
Yep, that's right. We have a system set up where they can refer into the Weems Cancer Center if we did this in this place. So that would be the situation where we'd set up the place to be able to refer them into, and then we would collect those and start setting up the appointments for those patients.
Okay, what insurance whatever the hospital took is what would.
That's right. Yep. We would,
So like CHP is huge in our county, so CHP would be on your network.
It would be on your network. So we
Or
would
our
credential
network.
the physician through the hospital, look and operate like a physician employed by you guys, but employed by us. So nothing would change on the insurance side.
So basically, this would be a department of the hospital.
That's right. That's correct. Yep.
Okay. And then as we look at our vision is really to provide quality care close to home. You know, one of the things about having something like this here, you know, especially when we see patients individually here that live down the street from the hospital, or even around the corner, but have to go to Panama City or Tallahassee, you know, so that's very important. The other thing that we're looking at, you know, because we're looking at space. You know, we want to grow. You know, we want to begin to grow our services here at the hospital, you know, so we have to carve out space in the hospital. Space is very limited, you know, we don't whole hospital.
However, we think we can make it work.
But we can
don't
make it work, you know, I mean, my thing is to remove barriers, you know, to make it work. So we're looking at, you know, I think the idea was looking at a couple of rooms, a room in the med
We had that
surgery.
big room in the clinic
Yeah.
that you and I looked at, and then we have a room down Med-Surg Hall. That would be perfect.
Yeah.
Jeremy, could you also explain how you guys offer other infusions other than oncology infusions?
Yeah, so if there's a need, there's other specialties that, you know, align with infusions, and we can kind of go down that path to be able to offer those as well, if they're not offered here already. We're not looking to take things away that have already been offered here, but just to add services to keep it closer to home.
Yeah, another thing too, that we may be able to
if-
use some of those.
If somebody was our clinic and blood work didn't look right on their physical or something like that, then could they make a direct referral to y'all?
Absolutely, that's exactly how
See,
it would
that's-
work.
Okay, just, you know, go across the street right here and of course, someone might not want to, you know, that's
Yeah.
up to the patient right there, but it would, I think people around here might not get treatment because they can't get to Tallahassee.
Yeah,
I
exactly
really
what
think
we
that's
said.
happening. you know?
Yeah, some people can drive to Tallahassee, they have family members, but some people cannot. You know, so it's a decision that they have to make. Someone may not go to Tallahassee or Panama City to get that kind of treatment. And to have something like this in the community, you know, it would create that access for them. You know, they can come to the hospital, you know, because everybody cannot drive to Tallahassee. You don't have family members for that. to drive.
So we provide a nurse and we provide our pharmacist. You provide everything else, correct?
You provide the space, and we
provide
would
the
reimburse
space.
you for the space, so basically renting the space.
So
from
you're
you
renting a
guys.
space from us?
That's right, and that's all we would need.
Yeah.
Mm-hmm.
Yeah, I think another point, sometimes referring providers in the community are actually tentative to make a referral to an oncologist because they're not sure it might be cancer or not. So they
Right.
put them through more testing and all this sometimes unnecessary work.
Right.
Our thesis is if you think there's any little chance that cancer could be at play, refer and let us do what we do here. And I think that's an important distinction because it's just kind of how healthcare has evolved. And we kind of want to change that to just help in
Yeah.
case there's anything.
Yeah.
So they don't need an incredible amount of workup or all this, just send and we'll do it, take it from there.
So what would be the financial impact to Weems Memorial Hospital?
Yeah, I don't think we can say
we're
exactly.
dancing.
Yeah. I don't think we can say exactly what it would look like for you guys until we actually get into it. I will say, like, our investment would be our investment, no matter if we see one patient or 100. So we kind of carry the risk for that. Where you guys, it would be, you know, if it works out, it works out. But who knows what the actual dollar number would be?
Jeremy?
Yeah.
Do you, Do you have an idea of what your break-even number of patients are for you to make it worthwhile?
Yep.
So admittedly, we're still learning that, right? So as you can imagine, we get, files back to figure out what was spent, what was reimbursed, et cetera. It takes a little bit of time. What we pro forma'd for was around 25 patients a month to break even. And I would like to just pause there and say, that's where the community comes. So as you guys think about this, that's our ask to the community, is once we're live, to help promote it, to make sure that people understand that this great service is local now. And so we spend a lot of time after like the clinical implementation, making sure the market is well aware. Because to the point earlier, referrals aren't just gonna come from doctors. They're gonna come from folks in this room.
Yeah.
Have you done any kind of study as far as how many people from this county are being lost to Tallahassee for infusion therapy? Have you figured out what kind of numbers that looks like?
Yeah, I'm hesitant to say a number out loud.
No, I don't need an actual number, but I
Yes.
want to know that you did some of the research on
Yeah.
that.
Yes, sir. So what I would say to that
Wanted
is,
to hear.
yes, of course. And what we've done is looked at what's publicly available data, where Jeremy mentioned incident rates, there's also mortality rates, et cetera, for us to get an idea of what we think is out there, both in like folks that have cancer, but also those that aren't getting treated by it. And that's again where the mission comes in, is let's save that.
So you're saying there's plenty in our community that aren't getting treatment because they don't have transportation, or they've just given up because
right.
they don't have family or they don't have any support. And those are the people that we're trying to reach as well.
That's right. And I would say like there's hundreds of patients in
I agree.
both
No,
counties.
I can
Yeah.
count 10 off my hand right now,
That's-
personal friends.
That's right.
So, yeah, I better go in both ways. And like I told you last time you were here, I have a friend that she told me her husband has panic attacks the whole way there because the ride is so horrible on the way back after his chemo treatments. It's long. They have to pull over the side of the road. And she said, I would give anything if I could just get 5 minutes down the road. She's a personal friend of mine.
Yeah.
If I can just get 5 minutes down the road for my husband and we wouldn't have to take the whole day. She owns a local business here. She has to shut down her business for the day to take him all the way to Panama City and back.
Yeah.
So this would be huge for her family. Even if we can reach one family, in my opinion, that's enough.
Yeah, we agree.
Well, a lot of outpatient surgery here. It would have been an outpatient in Tallahassee. But since it's so far, the doctor said, you need to spend the night here, I mean, that's what situation we're in. We like living here though, so-
Yeah.
But that's the same thing. Your doctors, now, I don't know much about licensing. They're oncologists, and are they licensed nationwide or per state, or how is that?
It's a per state, yeah.
Per state?
Yeah.
So you would have
take care of all
everybody
that.
be licensed
Yes,
here?
sir.
Okay,
That's right.
all right.
I have a question.
Yeah.
Do we have to try to get these patients like we do for swing bed patients? Do we have to go up to the hospital and try to basically hustle them to come down here?
No,
No.
I think the goal to be able to get those patients in is all through building relationships with primary care, to let them know that we're here, and then let them know that this is a place they can refer the patients into.
Do you have any relationships with the oncologist up in TMH?
We do not, no. And we wouldn't be looking for the oncologist to get referrals, we would be looking at primary care where they're getting
Yeah.
diagnosed with
Right,
potential cancer,
okay.
to refer them in.
Yeah, but Susan can tell you how it worked, because from a, come on, Susan, come on.
I love it when he puts you on the spot, Susie.
Well, from a clinic perspective, because
Buy her lunch, Walker. About Susie lunch.
really, all your referrals like this comes from your primary care physician.
Right.
It does.
Yeah.
So I guess we're hoping that the outpatient clinics are gonna support this by funneling people that are in need, right?
In Gulf County as well.
I
We
don't
can't forget
think-
Gulf County.
Yeah, I don't think people really realize how many different types of cancer are out there too.
You're absolutely right.
And just as they were speaking to, you can also send somebody, if there's a thought that there may be that process, then they have somebody that's a consultant closer
Absolutely.
to home, could nip it in the bud before you can get on the books with somebody months down the road. And for me, seeing our patients, the transportation is the biggest deal.
Yeah.
And I know several of our patients just in our office, that we're not talking about FAR or North Florida
Yeah,
or Catlin or anybody. We're talking about just
Right.
our office.
Right.
How many patients I see that have cancer, and I know a handful of them that didn't get treated because they just didn't have that support.
That's so sad.
So, and then there's the other types of infusions. So I think it's worth us looking at, in my opinion.
And your turnaround time is 3 days, right? And you've
Right,
got
and plus
patients
just
that are
the-
waiting weeks.
The idea that you know, you can go into our hospital and go visit your family member. Be there.
Absolutely.
You know,
That's
depending
wonderful.
on their regulations as far as having visitors or whatever, because chemotherapy, of course, you have to be in a more serene and
Right.
clean environment.
Right.
But still, somebody can come and pick you up
Right.
and go home and be there to hold you when you're going home.
That's exactly right.
I have a brother going through it, so it's a tough thing.
Yeah, absolutely.
We good?
So,
Thank you, Susie.
You would see, you would see a need, you've worked in the clinics, how many, okay, good.
Been in the medical field for 40-plus years.
Oh,
And I can
at
tell you,
least-
we have a need here,
Mhm.
and it's
I
sad to
agree.
me that we don't have it for our patients. If
I agree.
we
Gotcha.
don't have enough financial support in the area, this would be a great asset.
I agree.
Okay,
So what do we do moving forward?
Yeah, I mean, I think the best next step is to kind of dive into the details of it with you guys, to explain the agreement, kind of what it looks like, to make sure that you guys know all the ins and outs of it, which should be no surprises is the way we approach it. It's like what we talk about is exactly in that agreement of how it works and operates. But go through that, and then you guys can make a decision on.
So who draws up the contract? Do you guys
We
or
do.
our attorney who would draw up that contract?
well, a
contract?
county
Who
attorney would have to be involved in that.
So,
Yeah.
so what we would do is we would send you the contract that we use for him to review, him or her to review,
Mhm.
and then get their feedback, and then we can take that into account of what we can accommodate or what we cannot.
I mean, at first, our first barrier was space, but, I mean, we've pretty much agreed that we have the space. We went over every inch of that hospital with you.
Yeah.
And we agreed that even, like you said, we would need a hood. We need to put a hood for mixing drugs in the pharmacy, and we have that. We have a spare room right next to the pharmacy, Courtney and I.
Yeah, it's been utilized before, and we don't have space by any means.
Right.
We can accommodate space. We're going to take a patient room this one day a week for treatment, so we're going to be utilizing a patient room down the patient hall, and we're going to take the swing bed coordinator's office, which is used for many other things as well.
And we can put the hood in there because you have to have a special hood to mix these chemo drugs, but we think we've found the space for that. And you supply that, correct?
That's right,
You come
yeah.
in and install that.
That's right. We would supply it and put it in.
Okay,
Courtney, did you finish what you were saying?
Yeah, I mean, I feel confident that we can make it work, but we do not have space, in my opinion, we need additional space, I'll say. We'll make it work. We will make it work for these guys, but we're losing other, you know.
yeah, we're gonna lose some
other-
space somewhere.
We're
but
losing space.
I believe this is
We've got
worth
to
it.
grow.
Yeah, I
Mhm,
agree.
mhm.
Yeah. And one thing about this, my idea is always to create access to care close to home. And this is such a touching environment that we deal with every day, the people that we know of. But once we get the agreement, we'll send it to Schuler, then we'll send it back to the board too, so the board can review the agreement as well. And then we'll see what we can do. But I think this can be a good win-win situation for us. Just think about Weems Oncology Center, Weems Cancer Center. Patients in Franklin County and surrounding counties can come here
Yep.
instead of driving it 2 hours back and forth. But like Courtney said, we'll make it work. We're squeezing ourselves out of the hospital, which we need to do because we need a new hospital as well. But anyway, that's another side story on that. But we'll continue to work with you all, come back, we'll get the agreement, and then we'll pass it to Attorney Schuler. We'll bring an agreement to the board, let the board review it as well, and get their thoughts.
To try to move on, I think it's excellent. Is the board all in agreement to proceed?
Yes.
Yes.
Okay, proceed.
Thank you, Jeremy.
Yeah, thank you,
Thank you,
guys.
Jeremy.
Appreciate it.
Thank you so much. Thank you both.
Kristen, you did a lot of good work on this. This is a thing that was handled exactly perfect, and
Yes, sir.
Mr. Boland, I think you jumped right on it. David, both Davids, y'all
What
jumped
do you
right
think,
on it
Bowling?
and didn't let it lay out there for 6 months and not do nothing. So that's good.
What do you think,
No, I
Bowling?
think, yeah, and I met with Jeremy,
I'm gonna skip
Actually-
around a minute.
met with Jeremy up in
We got
Nashville. I
Miss
think
Esther
it's a
here.
good thing. Let's move.
He was talking.
Oh, I'm sorry. I'm sorry, go ahead.
No, you're good.
Go
I
ahead.
just asked Dick Bowling what he
Please
thought
go
about
ahead.
And I said, no,
Please go ahead.
no, I'm sorry. No, I think what these guys are working towards, I think it's a great thing. I mean, again, trying to bring, a specialized service like that, as David said, closer to home and keep the patient and deliver the care here. I mean, that's a great model.
Do you have
And,
anybody else, David, doing this in your other hospitals?
We got one that's up in Kentucky that started a very similar approach. And of course, in smaller communities, it's got to be in partnership with someone. It's not Main Street, but it is another group that they have worked with internally. But again, to provide that care, you do need that.
And that's working out pretty well for
it
the
is
hospital?
working
And
out. It is.
Good.
Yep.
We're good.
And that's pretty good, because we're 4 minutes past schedule, but we're right on time. Go ahead.
Move.
Okay. We got Colleen here. Would you like to come on up, or you want to sit through the whole meeting?
I'm happy to sit.
Okay, fine.
Leave my girl alone.
I didn't want to, okay, I just, I know how it is.
Leave my girl
sitting-
alone.
I've been there, done that, trying to sit through a meeting and then, okay, when I could have took. Okay. Courtney, clinical services report.
All right, good morning.
Good morning.
I'm just going to run through some things as we carry along, but feel free to ask questions. I did want to mention that with this cold weather we've been having, we always work with the EOC and the Department of Health and bring in patients for shelter. We've discussed that before, but we did that this week. We're planning on bringing another this weekend. So it's nice to have that working relationship. James picks the patient up, brings the patients to us. We admit the patients, keep them warm, feed them, and then when the freeze or the cold weather is, yeah, so we had one, we got another one coming this weekend, so it's a nice working relationship with the county, Department of Health, EOC, and James as well, and his department.
I love that.
We've also been working with the Sheriff's Department on a few patients. Bill Williams, as you know, is a great asset, in my opinion, to this community and to the Sheriff's Department. And so when he has been contacting myself and Mr. Walker about some potential admissions so that we can get some patients in the community to safer places they need to be. So we've recently done that, worked on 2 of them and completed 1 of them so far. So I just think that's good. It's always good to work with the Sheriff's Department, and Bill's always great to work with as well. I just wanted to also update you guys on this refuge house sexual assault thing. The refuge house and Doris Carmichael and myself, we still meet every 2 weeks, but it's a work in progress. Building those policies, we found the space, identified that, but we're having to get sexual assault nurses, and so that's what we're working on now, getting the training brought to Franklin County.
Certified court?
Mhm. And we can do that, and I had 2 nurses do that, but they went to Tallahassee for a week. And so we're working now to get that training brought to Franklin County so that we can have more providers that can do it, because it's hard. It'd be hard for me to step away for a week and go stay in Tallahassee.
Yeah.
And people like Doris, who's very active in our community and is going to be one as well, she can't close her office for a week. So that's where we stand now. We have another meeting. We just met last Friday. We meet every other Friday. So I'll just keep you updated, but I just want to let you know that's still working. It's just a process. Then the swing bed's still going well. I've got one that's been there a little while that came into emergency room. We had shipped that patient out, and then she returned back, and then one of them came through the WellSky referral system with the assistance of Lori as well. Hospice, so Mr. Walker and I are on the Big Bend Hospice Advisory Board, so we meet monthly. We are hosting the meeting in February at Weems. We've invited Colleen to come as our guest to kind of get involved on that as well, because we are planning an open house for the hospice room, a ribbon cutting ceremony. When we nail down that date, the meeting will be this month, the 11th, and then we're going to iron some things, and I'll make you all aware. But shooting for April, so we'll keep you posted there. But we've got some updates done. We've got some things we're going to do right outside of the room, some plants and different things like that, and some updates going on in the room as well. So hope you can all join us then. And otherwise, we have one full-time nurse that I got hired on night shift. So she was PRN with us, and we did some talking and figuring, and we got her full-time, so she'll start in March, so there will be overtime this month, if we have to cover the shifts, but in March, we've got another full-time night shift nurse coming, so.
Good. That's good news.
Yeah, yeah, we'll keep working, so that's all I have, unless you guys have any questions.
That's good news.
Yeah,
Thank you.
it is. Yep.
Good news. Okay, any questions? Okay, thank you, Courtney, I appreciate that. Next is the EMS update. Mr. Osteen, James.
Good morning.
Good morning.
I got a few things here. The first one is the EMS county transition. It's still moving forward as smooth as possible, as smooth as I know. I don't know a whole lot about it. Our consultant Louis, the consultant, him and the county people are the ones talking to each other. I'm kind of left on the outside right now, which is a good thing, I think. I do know the EMS director application process is supposed to be opened up today, and it's going to run for 30 days. And then after that 30 days, they'll do the interviews, and then they'll select who that person's going to be, and then get them in place. I think the April 1st thing is going to be tight with this. I'm not sure, but just in my mind, I'm thinking it's going to be kind of tight. But I don't know, and who knows? April 1st.
That's right, in the middle of spring break too, so yeah.
It don't really matter. I mean, it needs to open, the conversion needs to take place when it can smoothly. I mean, that's what
Right.
my idea on it.
The thing is, just from
it's good to have a target time, but
Yes, sir.
I don't know.
And my understanding is after the EMS director is chosen, then everything will open up for the EMTs and paramedics.
Yeah, sure.
And stuff,
Sure.
so.
Yeah.
What does that mean? Everything will open up for the EMT?
The application process for the EMTs and paramedics will open up, will be posted. They'll do job postings also on those.
Is that for the ones that we currently have?
Yes.
Yeah.
Everybody has to
Oh,
reapply
okay.
because it's
So
a new
transition
business.
process.
So everybody has to reapply for their,
Okay.
essentially for their jobs.
Now,
As far as the extrication equipment goes, I talked to the gentleman at Genesis, actually didn't talk to him, emailed him, I got an email response yesterday from him. We did order the extrication back the day after we got it approved here, so it has been ordered. We're supposed to receive it, they're supposed to receive it at their building in Tallahassee in the middle to latter of March, and we should get it shortly thereafter. I did speak with Mr. Ray Pierce, John. He told me what he told you, and then I spoke to the actual the fire chief over there.
well, explain to me what's going on, because I haven't conversed with
Okay.
anybody.
Well, I
before.
talked to the fire chief, Caleb Harper, and he said that that's not happening. He said they're keeping their extrication equipment.
Okay.
So we're not going to look into the whole getting.
Let
that
me
from
bring
them.
you all up to date. What occurred was Alligator Point bought all this the Jaws of Life several years ago. And I got a phone call, basically it said, hey, we want to get out of this business because batteries and those things cost too much to renew, buy new ones.
Right.
So I had to bring, whatever you want to call it, says, okay, look, if you got the equipment, get it transferred over to EMS, and then they don't have, because the equipment's not going to change that much, all right? But the batteries are the recurring cost, and when we discussed it before, we didn't really have a handle on the recurring cost that it was going to be and how often we were going to have to replace these. And then if you use the multiplier of how many vehicles you're going to put it on, so it's got the countywide availability, that's going to increase your cost. So got him in touch, Ray Pierce was in touch with EMS and get this discussed. Now he's saying he's back at the fire chief that we have over there is backing off of it. So the president and the fire chief evidently weren't communicating whenever this
this occurred. So,
So they are keeping theirs, and just, I did reach out, and I did ask about the battery expenses to replace the batteries, and they're about $1,000 a piece to replace the batteries on them, whenever they need to be replaced. But they are the lithium ion batteries, so they last a good while before.
I was gonna ask you
They've
what's the
they've lasted
tough-
about 4 years, I think, 3 or 4
Okay.
years.
So the batteries that we have.
but his comment was it was $4,000 for the replacement at if I understood him correctly. And that's when the antennas went up, and I said, okay, look, we need to back this thing up and make sure the board understood what this recurring cost is. That's it.
So for us, then, the recurring cost would be $1,000, James? for the
And
battery?
that's every.
Every
and
4
that-
years-ish?
And it depends on how much they're used, how often they're used. If you can't overcharge them. You can't put them on charge, just leave them on charge for months at a time. You need to charge them, take them off the charger.
Okay.
That's a good way to kill batteries, as anybody knows. So as long as you take care of your batteries, you get 4 or 5 years out of a battery.
Okay.
And we get, I think the set comes with 2 batteries, so you can change them out.
Interchange them.
So,
And we made the decision to buy one set, if I'm not
That's
mistaken.
correct.
Yeah, we did.
And you were gonna get some more information about it for us the last time, warranties and so forth. I don't think we had any information on that. And that's where we are, and that's what I expected we would be hearing about, but that's whatever the company has sent to us.
but that's where I'm at there. Now, the other part, I don't have any further on the extrication right now, as far as warranties. There is a warranty on it, I have to go look it up.
Okay, did
I
you
don't-
come up with your deployment plan as far as how you going, where it's gonna be put?
It's gonna be on the QRV, the captain's truck, is where it will be. Because that truck goes, it wanders all over.
And how many people have to be trained on it? And, because it's all pneumatic, right, if I'm not mistaken?
It's all, yes, it's all
All pneumatic.
all battery powered.
Yeah.
There's no hydraulics or anything to it. It'll be, the 3 captains will be trained on it, and myself will be trained on it. Only because if the captain's out, I may very well have to step into that spot
Right.
to cover that truck. I was in the process, and I haven't finished of getting a set of gear for each captain and myself, but I haven't got there. But what I did look at, it's about $650 per set. That's the suit, the gloves, the helmet, and eyewear.
Okay.
So, don't have those exact numbers with me, but I've been working with Alliant Purchasing on some of that, trying to see what their cost is on it. And honestly, their cost's not a whole lot different than anybody else. All right, so that's the transition, that's the extrication. Overtime, we've been fully staffed, thankfully, okay? But then, as soon as I get fully staffed, something's gonna happen. Then I had one of my girls go out with a broken ankle.
Oh, no.
Then I had one of my guys go out with a knee replacement surgery.
Oh, no.
So it's always 1 step forward, 2 steps back.
Oh.
So overtime's still up, still not fully staffed. It was fully staffed, but not fully
But it's
staffed.
better.
All right, plus the flu's been just knocking my
Yes.
guys down here the last few weeks. So, just to give you a base, I just did month to month right now. I do have it breakdown if y'all want to know what it is per 2 weeks, but December, my overtime was $14,300. And for January, I'm sorry, yeah, trying to know it's January. From 12/29 to 1/25 was 20,252.
Okay, is that, out of that, you got built-in overtime?
I think this is just the added, the additional overtime.
Is the
Oh,
over
this is
overtime.
more.
Over the overtime.
This
How
is
many-
over the overtime.
Okay, dollars or hours now? How many, dollars?
This was in dollars. This is $20,252, but
Okay.
it was a total of, it was 400 and somewhat hours this last pay cycle.
Okay.
I was just knocked down. Like I said, flu bug's been killing us all.
Even though you're fully staffed, you're not fully, you don't, there's no relief factor built in anywhere for somebody being out. Overtime is a relief factor.
Whether it's overtime, whether it's annual
I
time.
understand, I understand.
The real thing, is the cost going down now that we got full staff? What I'm hearing right now is it's not going down.
Here right now, since we've been fully staffed, it has not. It's been about a little above, but it will go down once we actually get everybody in place. I don't have 3 positions to fill anymore constantly.
Right.
So
Hope so.
it's just, if I can keep everybody from breaking ankles
There's
and
light,
getting
James,
sick.
there's light.
You know, you're gonna have overtime, you would be better off some way if you could get a relief factor in for annual holiday, you know, I mean, if you could. And-
Well, my only
and-
relief factor in that is my part-time, and I've got a couple of part-time EMTs, which I've been working them.
Oh, have you?
In the
Okay,
spots,
that's
but
good.
I have no part-time paramedics.
That'd be
so-
good to have some part-time people there for a
Do you
relief
have
factor.
do we do PRN for EMS as well?
PRN.
PRNs,
Yeah,
yeah.
what's I call part-time. but
Part-time
yeah.
PRN, okay.
Yeah, I do, but, you know, I've got 3 EMTs that are
Mm-hmm.
PRN, and then I got no medics that are PRN.
Yeah, PRN.
Hey, James, if I can make a comment, back to the, back to the overall cost. I mean, and since we've been able to break out the, you know, the financials separately, and you have the EMS in your board packet, but from a total operating expense standpoint, for the 3 months of this fiscal year, I mean, they're essentially flat. I mean, they're actually under budget, $1,500.
Are they? Okay, good.
And compared to prior year, so the same 3 months in the previous year, they're flat as well. They're actually over $671. So, I mean, from a salary standpoint, personnel standpoint, as James just mentioned, from a budgetary standpoint, they're over budget by $1,000, and they're over prior year by $4,700. So they're doing,
Pretty
like you
good.
said, through
Yeah,
through
good.
December. Now, I think, you know, the thing he just mentioned, with overtime jumping from 14,000 in December to now 20,000 through January, now you would expect, obviously, they'll be over budget in January
Okay.
from that. But again, valid reasons with, you know, staffing situations that you have, but they've done a great job the 3 months of this fiscal year thus far with managing.
Yeah, I think so
costs.
too.
So you would have been in a profit if the workers when they got hurt, James.
I'm gonna wrap them on bubble wrap. Especially if they go on vacation to go skiing or something, I'm gonna put them on bubble
Yeah,
wrap.
no skiing.
All right, that's all I have, you know, unless y'all have anything else for me.
I don't really have
How many
anything.
times did we get caught without having an ambulance here?
Actually, I mean, short of, as far as being out of ambulances, period, like, all runs, I think this month, we've had 2 times that we've all been out where we haven't had anybody to respond until we get somebody available.
How many times have we used the helicopter service?
I actually used them quite a bit. I haven't got the exact numbers on there, but we've probably used them a good 10, 15 times this month.
Wow.
I mean, they're legit calls. I mean, they're going to be your legit heart attacks or strokes.
Do you know what their break-even point is as far as what they have to have?
I do not.
You haven't had a conversation with them as far as
I
how
haven't
many
talked- I
trips they
haven't.
gotta make it to make it?
I want to say that last time I talked to Tommy, and he was around the 25
Yeah,
to
25,
30
yeah.
mark to be able to make it.
And each time you use them, it doesn't cost us anything, right?
You know, it may not cost, but it does cut into my budget as far as my mileage, because we bill by mileage and by a base rate. So it'll cut into my revenue as far as mileage transporting from here to Tallahassee.
Okay.
Because I just get paid now if we fly them from patient's residence or where we pick the patient up to the landing zone. So it does cut into revenue there, but that's
But
what
the
revenue considers.
positive side of it is we've got the service still available in the county,
Yeah, that's it.
which is,
And we're clearly using it.
how do you know, cost that out. I mean,
Okay,
You
that's
can.
good.
you can't. So I'd much rather be in that situation where you were less than and not have the service here in the county.
And if we have flown anybody out that really didn't need to be flown, it was because we didn't have an ambulance available, so we just went and used them as a fourth ambulance essentially, let them fly the patient out, so we still had a unit here in the county, rather than blanking the county of everything.
Do you know of any conversations that have been going on with the other counties as far as trying to come up with a mutual plan of attack with using these helicopter service?
No.
And I did, while we're talking about the helicopter, part of the agreement, we had an agreement, trying to get agreement in place with Air Methods. The board has approved it. But I know they had a question about the landing zones in Franklin County that the county commission wanted to put in there. So I'm waiting on Tommy Cochran to email me back the agreement saying, they agree to put that information in that. Then we have that agreement at the hospital for Air Methods here. I know Air Methods also, they may be looking at going to Calhoun County, I think, that area per se. I know Calhoun County also have, who they have over there? They have, survival flights.
So can you elaborate a little on the landing zone, what's going on?
Yeah, we have about, is it 6 landing zones here?
Maybe it's 6. There's one that, there's one I'm not fond of. I really don't like using it if I don't have to, but unfortunately,
So there are different areas in the county that Air Methods, if James is out there in the field and they need a helicopter here, there's different areas in the county that Air Methods will come in a helicopter really will use to land in that area.
There's 6 total.
Yeah, I think.
I have Apalachicola Airport,
Yeah.
is one. The field next to the sheriff's office, the big empty field.
Mm-hmm.
Not hot about that because there's not an actual pad there.
Right,
They're
I agree.
landing in the field. If it rains, it's terrible. I've seen them laying in there and start tipping.
Oh, my Lord.
So I'm not a fan of that one. Then we have the Carabel Airport. We have and we can use it as long as they can get high enough. We can use the St. George Island Airport. We got Lanark, just out at the Hefferman Drive, right there, and
Hospital.
we have
How about our
the one at the hospital.
Carabel Clinic.
There is one at the Carabel Clinic, but they refuse to use that one. The pilots won't use it.
They don't like it, it's too tight.
They have to literally come straight down and then
Yeah.
straight up. There's too many trees. Then they can't make their approach inland.
I get it.
They literally have to go in and hover down.
I get it.
And then up. They won't
What
use
about the
understand.
one at Alligator Point?
it. The new one, they're not going to use because it's right there in the parking lot of the new fire station. They won't use that one because it's just too close to everything. They are currently still using the old one at the old fire station, but how long is that's going to be there, I don't know.
But there's been conversation also about building one right across from the old firehouse there. Where's that conversation? Or have you
I
been
don't know.
involved in it?
I have not been involved in that. I'm not sure about that.
What's
I
gonna
don't-
take place is that they're having to redirect one of the roads that come around where it used to wash out a lot at Alligator Point, and they have a landing zone there. But when the road gets redirected, it knocked down the old firehouse, that landing zone is gonna be absorbed by a portion of the road. So they have to find another spot to land it, and that another spot was that the county owns about, 4 or 5 acres right across the street. And they're talking about putting that in there. Now, I don't know where that conversation is going right now.
I know they've also talking about if y'all are familiar with FSU Marine Lab, pretty much across the street, across 98 from it is all you see is woods, but behind that's a big open field. And actually on that mock drill that we used, that we done out there, the shark encounter mock drill a couple months ago, they actually landed over there. So then they said they really like that area, so it's easy enough to land in. So they're considering getting with the FAA and potentially making that an actual LZ.
Who's they, the county, the commissioners?
Well, the FSU Marine Lab.
I know, but so they are thinking about making this, a
I'm
place.
talking about the Marine Lab and.
Yeah, is our county doing that?
I'm sure they will. I'm just saying FSU Marine Lab would like to, they're gonna look into, I think that's their property.
Okay, so they'd have
So,
to work with
so
the
I
county.
think they're gonna look into it, and they'll probably work with the county if that's what
Okay.
they opt to do.
Okay. All right, anything else?
I'm good.
Anybody?
No, sir.
Thank you.
You do good work, James. Thank you.
We got finances coming up. Let's take 5 minutes. I was wrong about finance. We have safety environmental, Craig Gibson. Susie, I'm sorry. The clinic update, Susie, I'm sorry. I'm glancing at
She was just saying she can't wait to get back up.
I glanced down and I didn't have my glasses on.
That's okay. Did you try the last name? No?
I still can't pronounce it.
Yeah, that's okay.
My wife's name's Susie, so I just say Susie.
Yep. Well, good morning and Happy New Year, since we haven't been here. So I only have a couple things to report. One thing to look out for is it's the new year, so of course people are losing their insurance. They're dropping out. WellCare pulled out of the area. And this started back in December when people were changing their minds about insurance. So we're making sure that we're offering the nice financial assistance packages to patients, so they have opportunity to join that if they can with Weems. It's just, keeping people compliant if you don't have health insurance is kind of a tough thing. So we're going to make sure we educate everybody in the area about that. We are still working with United. We've had a 3-year battle with them about credentialing, but I think we've come to an agreement. They came out to the clinics and they did an inspection. We're fine. And so we'll get that process moving so it's not so hard for the United Healthcare patients to get Dr. Conrad on their card, so that it's deemed with him. Let's see. We're still one of the few people in the area that do outside labs for everybody at the clinic setting. So that's a nice opportunity for patients to come to us, and we do prefer to have it a scheduled lab so that we know in case we have staff call out or something, we need to change the day, we can call the patients and reach them, but we do still take walk-ins. And speaking of customer service, we are putting in coffee stations at both clinics. You brought it up, it was one of those things.
You got a new place to go, Duff.
Not flavored creamer, but we might have the half and half.
Hey, I just wanted to have something I knew how to talk about at this meeting.
No, that is one of the things that patients really want to, is their anxiety level, right? Everybody's anxiety levels lately in the last several months have been here for a lot of reasons. But, when they're going in for labs and you're trying to get them, if they have that coffee on the way out, life's good, right? So
Wonderful.
we're going to do that for the lab part of the day. Right, and it's we'll put up signs just like McDonald's. If it's too hot, don't drop it.
That's right.
But one of the other good things that we're working with, the Weems Foundation is going to help us get some hospital beds for the clinic setting. We're going to do piecemeal as we have the funds for it. But one of the 2 beds we'd like to do, or I'd like to bring into the clinics since they're older, is a handicapped accessible exam bed, so that we can get patients that are harder to transport or mobile or a heavier weight onto these types of tables. So we're going to work towards that. So that's a great thing. We thank the foundation for helping us support that, and the hospital's going to match it, so that's good.
Yeah, and why Susan?
Stole my thunder.
Sorry. Anytime.
Well, while Susie's there, we had, and since we're talking about the beds, that we had on my report, we had a generous donation. Someone donated $15,000 to the hospital. And so once we get with that person, we'll bring them up and we'll do like a check kind of deal with them so we can recognize that. But we'll put that money, some of that money together with the foundation money as well, so we can get the beds for the clinics. And then we'll work with some other things. So that's what Susan's talking about when she said these the 2 handicap beds that we're getting be very, very important. And they're probably about $11,000 a piece.
Yeah, everything's gone up, of course, and so.
We need to do that with that big check. Somebody else, Mark Cuban might be coming by and want to give us a big donation or something.
Yeah, we're going to do it. Yeah, the person is out of town, but once they get back in town, we'll introduce them and come in and do that.
Wonderful. That's great.
Yep, and we're just, we're looking at other, there's been a few vendors coming by, bringing in, just like with the cancer treatment, but there's been a couple others trying to work with us on different products we can bring to patients. Something to do with patients that have hypertension and appliances that they can use, sort of like remote patient monitoring appliances, but they can take them at home, and it will help with relieving water from them. And we're still working at it, but we have a lot of vendors now coming to Weems, so that's nice. And one of the things we're going to be working on this year is the diabetes program. Since we don't have a podiatrist in the area, we're going to work on other portions of that to help with our diabetic patients in the area. And once we have that firm, we'll bring that to your attention. But I think we've got some good things coming in the works for the clinics.
And one thing about that,
Wow,
she's,
good.
the diabetes program, you know, we're looking at partnering with an entity to do some diabetic eye exams, diabetic screenings, not eye
Oh, that's
exams.
good.
You know, so they have they use AI in that particular equipment. So we'll be bringing that back to you all, you know, as we look to.
I'm excited
move
about
forward
that.
there. So that's going to be very exciting because we have a lot of individuals here with, you know, diabetes.
Susie, could we also bring in wound care if we have the diabetes program?
If you've got the space, sure.
I mean,
No,
we-
we've
no-
looked at wound care before,
Yeah.
but the program that was offered several years ago was a company that wanted to come in, sort of like a Main Street deal, but they wanted to take over the entire clinic for a couple of days of the week, and that kind of didn't fit our need at the
Yeah, we
time,
can't
but
do
I'm
that.
sure that we can look at other avenues with people.
I mean, if you've got the diabetes
But
program.
it works
that-
really well
that-
in the
yeah, that
hospital setting,
dovetails with
too.
that.
Yeah, it's
It
Absolutely.
just-
absolutely does.
Yeah.
Yeah, I mean, all of these great conversations, it needs to then go back to the county and say, hey, look, let's talk about the hospital again and where we're moving with it. We're moving in great directions.
Yeah, we
So
need
how about a
space.
building?
Yeah.
So,
Yeah, I agree. We need space.
we need space and it's warranted. It's
Yes.
here. And we're all aging to that time where we need more care.
Yes.
So, and people are living longer, so let's invest back in Weems. It's the great hubbub, so.
Yep, I agree.
Any questions for me?
Yes. You mentioned about United
Yes.
Insurance.
Mm-hmm.
Well, you're saying that if you have that insurance now, that you all accept that?
We participate with it, but there's been some, over the last 3 years,
Yes.
conversations back and forth, as you know yourself.
Yes.
And some other patients that, it depends, it's such a large corporation, right? So you know that Tallahassee dropped them, you know Sacred Heart dropped them.
Right.
They're notoriously not good at paying their claims.
Right.
That's things that the patients don't know on the background.
That's right.
But what you get as a person who's paying a monthly premium, you get a 1-800 operator who's looking at a directory and, oh, no, that doctor's not on there, even though they're credentialed or they're supposed to be in network. And a lot of times it is just directories in the background or portals that we maintain on a quarterly basis, Heather and I, and cleaning that up. And we check it all the time, but it's a matter of if you get a 1-800 operator or it's a little snafu in the background that somebody put in a long number the wrong way years ago, and that's been our 3-year battle.
Yeah.
But they recently came out because we've been beating their drum, and Mr. Walker and Heather and I just keep at it until we get, look, you give me a roster every month. So every month, insurance companies that we participate come out to the clinic, and we go over HEDIS measures, and we go over the patients. So my plain conversation to them is if I have a list of 174 patients, they're real people, so why isn't Dr. Conrad on that card? So you're taking the money from 174 people.
That's
Right.
correct.
So now we're at the point where they came out to the clinics, we're done the credentialing process again, just to satisfy their needs, and I think we're moving forward. So I should have an answer for you, hopefully by the beginning of February.
Okay,
Because it's already,
Susie.
what, the 29th?
I'm sorry. But I'm asking because, as you know, well, why aren't the people that have the insurance know this before? Because as you realize, I went through that. And because of that, I received a bill for $286 for one appointment. $300. So I think it's so outrageous.
So
that-
here's what
that
you have
we
to.
don't know about it.
Well,
So I
but-
immediately, excuse me.
Right.
So I immediately, when I left you, went home and changed my insurance because that shouldn't have happened.
No.
But I'm not saying that you all should tell
Right.
the people.
Right.
I'm wondering why doesn't United or whatever insurance it is.
Yeah, most insurances don't. So most insurances is, say, a lot of the Ambetters and the Sunshines, and they randomly pick, based on your address, the physician in your area 25 miles out. They don't have that conversation with you, right? They just get your premium from you. And then it isn't until the patient comes or makes an appointment with us that we verify it as we're with them and say, hey, wait, you have Dr. So-and-so on your card. We can't accept that. Oh, well, I didn't pick him. Because I think a lot of patients think once you get an insurance card, it's just like a library card. I don't have to think about it anymore. I can get in the door free.
Right.
And unfortunately, insurance companies don't take that time to tell you about who your primary care should be or ask you.
Right.
So it is everybody's personal responsibility, mine as a patient too, to make sure that I go to where I can go to that's in network.
Gotcha.
And patients just don't know that. So
Yeah.
we spend a lot of time educating
Educating.
patients at the front desk.
Well, you educated me. Yeah.
Yeah,
So,
and I
and I'm
think-
sorry that happened to you. I hate it every time I have that conversation for 3 years with somebody. But it's not just the United, it's all the insurance companies.
Yeah, 'cause
They
I'm-
don't make it easy for patients.
No.
No, they
Yeah.
don't.
And then the
Yeah,
more patients that don't have access to portals because they don't have computers or
is
internet,
right.
they don't have that information. And the larger insurance companies are not mailing out plastic cards. They're not mailing out a lot of the mailers that they used to get. They direct people to the portal. Well, if you don't have internet access, you don't have that information.
That's right.
So,
Thank you.
Yeah,
So-
thank you. And this is something that I was in Tallahassee yesterday with some CEOs, and they were talking to the legislators about, some of the legislators about this, some of the same issues with the insurance companies that, that saying that the physician is not credentialed, here, but they got a roster that's saying it, but when their patients call, they're like, no, he's not. So they're going back and forth. One individual CEO told me they've been trying to work with a insurance company for a whole year, and one is a year and a half. But the provider's been there in the community, and then they don't want to credential that provider, because it's not under the network.
Right.
And so I think that's something, and maybe we can put something on our website, on Facebook, to say, if you're, watch your enrollment, if you're changing your enrollment, please contact your provider to make sure that you on the network, that this is your physician here.
Yeah.
Because everybody really is not computer savvy,
That's right.
really.
Yeah.
So who do we have on staff that supports these people?
We don't, usually, if we don't have anybody on staff specifically that support them unless they come to the clinic, and then Susan's talking with them. Many times it's the clinic area, it's not really that you're coming into the hospital per se, because once you come to the hospital, we got to serve you
it's
regardless.
mostly in the clinic
It's mostly
setting.
in the
because-
clinic.
Now, you're talking about customer service, because we get reminded every meeting right at the beginning. So why don't we get somebody that knows the ropes of this stuff stationed with the hospital, that these people who don't have the know-how nor the capability to understand, well, they got the capability to understand because it takes money, but don't have the capability to interface correctly with these companies. Why don't we have somebody that can be that type of liaison?
Well, we talked about that before, where we have the Shine group that's in the area. They go to the local libraries and they help people with Medicare products. But, they're very knowledgeable people and they help you with other insurance programs too. We got the zillion commercials, but we were also talking about it before, about a grant that's coming forward to try to see if we can identify some money set aside just for that, so that we can help people with their financial assistance packets, with some Medicaid plans, with other things to know that. And trust me, I talk till I'm blue in the face about
Oh, yeah.
insurance.
I bet.
Oh, yeah.
Oh, yeah. I
And-
bet you do.
I'm happy to help people, but it also, from having done it, I also have to tell people you have to be responsible for your own insurance
That
too,
is true.
right? You have to take a little bit of ownership about what you signed up for. If you're spending a good chunk of money every month, you should know a little bit about it.
Yeah,
So,
I agree.
Well, John, I think what happens in a lot of cases is people don't really understand until they go and have a claim
Right.
made. They don't get the upfront information when they're signing up, but when they have to go
Yeah.
for a medical issue or a claim, that's when it hits them that, oh my gosh,
Right.
this
Right.
isn't
And who
what I
can-
thought it was,
That's right.
and what patient can read a claim?
That's right.
And
Yeah.
then also, like you said, you saw the price of, that's the price of the visit, but what people don't understand, that doesn't mean that's what we're getting. So every insurance company has a contract, and we negotiate with them. We'd like to get $250, but, okay, I'll pay you $110 out of that. You go with that? So that's how that really works. So we're not really raking it in that way, just as a common basic thing, so. But I'll be happy to help you with
No,
anything
I'm
you have.
aware, that all of that money doesn't go to the clinic or to Weems.
Yeah.
My issue is, or was, that it's okay. You're correct. It's up to every individual to, be responsible for your own insurance, but it's my fault. However, everyone doesn't understand that. I
Sure,
understand that now.
sure.
But everybody doesn't understand
No, that's
that.
why we'd like to try to do something like that, a
And
program.
that's my advocate right there.
Yeah, and we looked
Because
at,
any questions I have, I go to the clinic, and they are nice enough to explain everything.
and we have also looked at, hiring
If somebody walked in having a problem with insurance, somebody would help them with it,
Yeah.
correct?
Yeah.
You? Okay.
Susie
All right.
did.
Yeah, and that's the clinic, and then if you go in the hospital part, we have Joe, the patient access supervisor there, she would assist them with their insurance
Yeah.
as well.
Yeah,
we-
but y'all, we can't, we can offer you the information we know about your policy as the basic. But if you paid for a lower value policy or a higher value, we don't
Right.
know the details of that. We can
That's
look
right.
it up for you and try to help you with it. But people also have to understand, we can't call on your behalf because it looks like
No.
we're swaying you to come to our business,
right.
right? So the patient unfortunately has to spend that hour, 2 hours on the phone with somebody, 39 minutes, right?
That's right. That's
So,
right.
we'll try the best we can, and we'll work forward to it. I don't mind talking, just,
You've done a great job.
any other questions? No?
No, this insurance, let's talk,
Yeah,
it's never gonna get resolved. If I wasn't on the board, I would think I'd take my insurance card in Franklin County. If they accept it and treat me, then I'm okay. I didn't, I mean.
Right, and that is.
Well, that's
and-
it.
me
Well,
too.
Yeah.
that's,
Yeah.
I thought the same thing you did.
Yeah.
Yeah.
And I don't know, people aren't happy with insurance companies, but.
Well, and now the new thing
They're a
is,
nightmare.
if you do get a card, their way of saving themselves as a corporation, money from printing cards, is not putting a name on there at all.
Oh, my
So they don't
goodness.
mail them out because they don't want to use the plastic. So they'll send you something in the mail, look it up on the internet, right, or a QR scan that people can't do.
That people don't have access
Then if
to.
you ask for a plastic card, you get a plastic card with no name on it. So again, it's if you don't know, to go ask, who's on my card is my primary care, right? So those are the conversations we have to have.
Thank you. Thank you so much.
Thank you.
Susie.
Wonderful.
Thank
Clinic's
you.
doing wonderful.
We're lucky to have you.
So, we did get the, we voted for the, our providers, our nurse practitioners. We voted on that last
Yeah.
time, right? Okay.
Come on,
good.
the RVUs, yeah.
Good. Okay. Mr. Gibson,
Good morning.
Morning.
Happy New Year.
Happy New Year.
I want to say one thing before I get started on mine. I have been over there with Susie a couple of times doing things and sitting in that front office with her when she waits on these customers. I call them customers as they come in. She is wonderful, as you were saying, Ms. Kroom, about educating these people, and they're just kind of devastated because they didn't know.
That's
They
right.
didn't go look it up. But she explains it in detail, and when they leave, they're so happy because it's been explained to them in simple English, and they go home and take care of it. Yeah, but it is a mess.
How many
Yeah.
Susans do we have?
Just
Need
one,
about 3 more.
unfortunately.
I'm gonna tell you what, my wife got prescribed something that was denied by CHP. And Susie laid with them till they said, okay, I mean.
Well, that's as a practice manager, wherever you go, you want to make sure that provider,
Yeah.
is an extension of your care. It's called continuity of care.
Yeah.
So it should be this way, your primary physician officer, if you have a question, you should be able to call them and get the answer. If not, you need to change your provider. And I know just talking with that, I know we had talked about, looking at a patient, what they call navigator, somebody maybe to hire somebody to help out with the insurance. We're hiring for administrative assistant, because I hadn't had one in a whole year. And I may put part of that duties of that maybe.
I was just gonna suggest that.
Yeah, part of that duties of that administrative assistant, need to help in that area as well, so.
We could advertise too, couldn't we?
Mhm.
Say, you don't have questions about your insurance, come over and see Weems.
Yeah, come see my assistant, hopefully, they have some work to do for me as well, but, but that's something that we're thinking about.
No, it's not.
So there's something that we're looking at also when we advertise that position, that person have those kind of qualifications there.
Yeah, that would be great.
Good.
All right, Craig.
All right.
Let's move on.
Okay, as you know, we've been working on redoing some painting and patching and everything inside the West Clinic over there. I've got hopefully just a couple more Saturdays with the painters come in and finish things up there, and we'll be done. I have gotten 3 quotes on the East Clinic in Carabel to paint the outside, and the first one was $29,500. I thought that was going to be way out there, but all of them have been really close. The second one was $25.50, and the last one was $22.5. And all of them include materials and everything. What they'll do is they're going to pressure wash the building, caulk where it's needed. We're going to, up under the canopies, when it was built, they just put the 4x8 sheets up there, and it needs lattice strips up there to cover it and make it look like it's supposed to. That's going to be included in that. But that's everything. And I guess what David and I want to know is, would you like for us to go ahead and we want y'all to approve this 22.5? And this is actually somebody that David has had work done with him. And
You feel good about them?
Mm-hmm. Yep.
Craig?
Yeah, I've talked to him a couple of times, yeah.
Craig, is this part of the building that we would consider taking down if we were going to rebuild the new section?
Mm-mm.
No.
No.
So we're not putting money into a building that we
That's
think
gonna
we're
be
going to
taken
tear
down.
down at some
no.
point?
No.
Okay.
No, that's Carabel. That's the Carabel.
that's Carabel
Clinic.
Okay.
Oh, okay,
Carabel.
okay.
Yeah.
I didn't
No,
hear you
that's
say that. I'm
here.
sorry. I didn't hear you. I'm sorry.
Yeah, we just
Yeah.
we call it East Clinic, but it's really the Carabel
Yeah.
Clinic.
Okay, I didn't even hear you say that. I'm sorry.
Sorry.
I missed
okay.
that part too, sorry.
Sorry.
Okay. Do I have a motion to approve the 22,000 bid, or would,
Motion.
second,
Second.
discussion?
Yes.
Okay?
You're talking about the 22,000?
Yes, sir.
Do you sign a contract with them?
No, I haven't. We haven't done anything. We will.
Waiting on us.
You want to make sure they got insurance,
Oh, yeah. Oh, yeah.
workman's comp and all that?
Yeah, I always do that before we do it.
Okay.
Yeah.
That's
Yeah,
it.
we have to do that. I'll provide that for Heather. That way we have it in record. Yep.
Any more? Yeah.
Okay.
All in favor?
Aye.
All opposed?
All right. I have been speaking with Tracy Busby. She's the works with the management experts. She is putting together another grant for possibly getting us all new hurricane-rated windows at the hospital. Hurricane windows at Weems West, which is next door to the hospital. Doors and windows there. The doors that would be replaced at the hospital would be our front entrances and our sliding glass door. All the other ones have been replaced. So I'm waiting on her to get some proposals for it. It's a grant. Don't know when it'll be ready. She handled the grant for the generator. That took us 5-6 years, I believe, to get finally. So anyway, I'm working with her. There's a couple of things. ACA, our state agency that regulates the hospital, they want to know who we're going to hire first. So she's looking into that to find out who is qualified that ACA has approved can put those windows in for us in the state of Florida.
We can use the same vendor. We had a vendor when Hurricane Michael came.
Yeah.
And I think two or three windows in my office had to be replaced, and that vendor was approved by ACA. And so we may want to give her that name, Craig. But ACA is very specific on who they want to use for these particular projects.
Yeah, because they have real specific design and how many screws, how far apart they are, Duffy. So that
That's
type of
what,
stuff.
140 miles, 160 mile an hour wind?
I believe it's 140 or 150 now.
Projectile,
And it's fixing to
140
change.
projectile,
Yeah, yeah.
Okay.
Yeah.
That's code now, Craig, I believe, isn't it? That would be code today, I believe.
Yes.
Anyway.
Yeah. Yeah, everything's gonna have to be up to code, whatever today's standard is, yeah. And it, it changes monthly, it seems like, on things. So, all right, we've already talked about the beds, clinic beds. Susie and I are working on that, trying to find the best ones we want for, price and everything. Some exciting news for me. I have Troy Morrison back, full-time maintenance, I've been talking to him, and he's realized he's better off with us than where he was. So he has started back this week.
Where was he?
He was at it's a set of housing, thank you, Jordan Bayou. He was the maintenance guy over 39 homes there. And I talked to him before he left. I said, "Are you sure you've done all your homework?" Yeah. I'm leaving. I said, "All right." And my part-time maintenance person, Chris Love, who's a police officer over there, he talked to him also, and so he decided to go. So we've been talking back and forth over since he's been gone, and I told him, I said, "You just need to come back to the hospital." They kept adding stuff and kept wanting to do this, and that wasn't part of the deal, the contract. And so he just said, he said, "Can I come back?" And I said, "Sure." So, absolutely.
Came back happy too, right? Happy to be back.
Oh, yeah. He's all smiles now. So, and I am too. But he's doing a really good job as he did before. So I'm just glad to have him back. I have added a new housekeeper. It's another young man. His name is Amos. He's only been with me 2 weeks. He is a quick learner, and he is working really hard at everything. I've talked to the staff that has come in to work with him, and they're saying, some of them told me that when he was folding laundry, they said, "I come back in here to fold laundry, and he's already folded it and put it on the rack so we can carry it inside." I said, "Well, good."
Good.
Yeah.
Good.
So he told me when I was interviewing him, he said, I'm eager to learn. I'm a hard worker. He said, "I'm ready to go to work." So he's probably in his 20s.
Okay,
So,
good.
yeah.
Wonderful.
So I've got 2 young men working back there now, and then I've got my 2 PRN people.
Okay,
So,
great.
Yeah, so we're moving forward. I am working with Image First. We're looking at possibly doing away with the laundry, having to wash it and everything. And so I've got to put together what I would save as far as detergents, utilities, water, electricity in there, and see if it's going to compare and will help us in any way. So I'm working on that right now. Getting some numbers together. I should have everything together by the end of February.
So where do they do their work?
They have 2 buildings. They have facilities. They have one in Tallahassee, one in Crestview. If we get into a situation where we have to have something, they can pull from one of those places and get it to us that day. They'll bring in everything we need. Hampers where your dirty linens go in. What I've got them to bid on right now is sheets, blankets, the necessity stuff, microfiber rags for cleaning, mop heads, some floor mats. It's 100% turnkey thing. But everything comes wrapped, sealed in plastic also. Each blanket, everything's sanitary.
How many days on hand is our inventory for these type items?
Right now, I keep, just because it's in our disaster plan, I'll keep enough blankets on there and sheets, all of that, for about 3 weeks.
Okay.
Yeah. And I'll do the same thing. We've already done par levels and everything for the ER, patient hallway, triage, CT, ultrasound, mammo, all those. I have par levels built in for them too.
So basically, if we got a bad storm or hurricane, we can last.
We would be covered, and they will. That would be another MOU. They would supply for us, provided like everybody else. If they can get there, they would supply whatever we need. The other thing about this is they do when they come in, the guy delivering will assess what we're going through and using. He will be the one that's going to up my limit or bring it back down and keep us in a price range that fits the organization. So maybe we don't use that much one week. He's going to bring in less the next week, and then if we need more, then we'll bring more. But we're going to have a backup there, that'll last at least 2 to 3 weeks.
And we have to do that also by ARPA standards anyway. We have to have backup. Something goes out, we need to make sure we can continue to go.
Yeah, because right now, so if the wash machine or a dryer goes out there, then we've got to go to the laundromat right now to take care of everything. Yeah, we've done that before. I mean, you do what you have to do.
That's right.
So, yeah, so. And that's not a fun day, sitting there feeding them the machine to get laundry and everything.
Take a bunch of quarters with you, right?
Yeah, a bunch, yeah, I have done it, but you do what you gotta do to take care of, the hospital. Tomorrow, I'll be meeting with, Brandon from, Oliver Sperry. We have some grant money to remodel, 2 of our bathrooms to convert from tubs to walk-in showers.
Good.
So we, like I said, we've got a grant for that, so I'll be meeting with him tomorrow, and I'll update y'all on that next month. I'm also working with Shilston Associates. They're going to be installing the next nurse call master system in the ER. We've got grant money for that, so it's going to be paid for out of that. Our new paging system throughout the whole facility has been installed with grant money. We are currently looking at chairs for the waiting room, the ER, the patient rooms, the ER rooms there. We've met with 4 different vendors. We met with Thomas Curry from Business Interiors yesterday. He's going to get us some quotes and figure how many chairs we need, weight limit, size of them, like bariatric would be for a larger person, to hold like 450 pounds, and pick out some fabrics for them. So we're working on that.
And Craig, let me just interject there. And one of the things, we've been looking at the, improving the chair lobbies, in our lobbies and our patient rooms for a minute here. I was at Calhoun Liberty, the new hospital over there, and I began to sit in one of those chairs. I'm like, man, this feels good. It feels good to me. We need to have one of these. So I took some pictures and sent to Craig as well. And a lot of the things that we're doing, really, is the Capital Rural Hospital grant money. I'll talk a little bit more about that in my report. Because if we didn't have the grant money, we have to get that money out of the healthcare trust fund.
Right.
So there's a lot of things that we're doing, because we're trying to preserve the healthcare trust fund. So when we get a new building, make sure we don't take that in. But so there's a lot of things that we're doing. If you are around the hospital, just come through and take a walk through. We have the new flooring in there as well in the lobby, as well as in the rooms.
Yeah,
the halls.
and speaking, last thing, talking about the flooring, I still have money for that flooring through a grant, and I'm waiting on the quote to come back, but we're going to finish up the patient rooms, and then we're going to come out onto the rest of the hallways and get those done, and then we'll start into the individual offices and whatever else, we need to do. Yeah. We actually had a comment on the floors from Mr. Curry yesterday. He said, I really like these floors. And I said, well, thank you. We appreciate it. I said, he said, man, it just livens it up. And I said,
does.
Yeah, it does.
You're right. That's a good
Yeah.
floor.
Yeah.
So
It looks good. Yeah. And as far as customer service, I meet most of mine. Every now and then I do get down to the patient room and walk in.
Yeah.
I have my EVS staff, knock on the door, introduce themselves, and ask if it would be possible if they clean the room. Some people don't want it cleaned at that time. Maybe they can come back. Like if we have a patient going out for a doctor's visit, that's when we go in and clean that room and make it, and they come back to a fresh room. I met a nice couple actually 2 days ago. They were from Nashville, Tennessee, and I got to talking to them and said, how you like this cold weather? And they said, oh, this is nothing. At least we're not in the snow. That's when I said, where are you from? Oh, we're from Nashville. They were here on vacation.
Nashville snowed in, man.
Yeah, Yeah, he said, no, we couldn't have picked a better time. I said, well, good. And sometimes I'll be walking up front in the front lobby. People come in, I'll talk to them, introduce myself, and they'll be asking questions, and I'll try to help them out, So that's mine. I'm all over the place. So
I know, make it a habit.
Yeah,
You've always been that way, though. You've always been that way. That's just you.
Yeah,
And I appreciate that.
No, and when I walk into the ER waiting area, because my office is right there, I'll come in, and if I see somebody that really doesn't look like they want, they're sick,
be there.
I'll just nod my head, and there's no nothing, so I just keep on going. And but I know the ones that will talk to you, and so I just try to talk to them. Hey, where are you from? Are you from
That's
here?
all it takes. That's all it takes.
Yeah.
And I think people are appreciative when you do that, too.
Yeah.
I mean, they're very appreciative.
Yeah, I do too.
The MRI, where we
CT.
getting with the MRI? What's the status of it?
Okay.
It's a CT machine.
You want my okay?
David, while Craig's up there, and you was going to probably talk about
Well,
it.
the CT and the generator, they're both on hold with ACA.
The CT, yeah.
yeah.
CT, I'm sorry.
Yeah, that's okay. what it is the engineers, the architects, they have left out some information that are codes. They just want to see that in there. And so they have 60 days, or we have 60 days to get that put in there. The architects on both ends, the electrical engineer is taking care of his side. Gary Gargas, our architect, he's doing his things. And Ted from the for the CT, he's taking care of his things. Once all this gets in place, hopefully they'll get it approved, and then we can hit the road running.
Okay.
Yeah,
In the
that's
C-
what we're waiting on.
In the CT, because it's two separate projects, well, but ACA,
Yeah.
we broke up two separate projects. We got the CT renovation room where I'm at, put a new CT in there, then you have the new generator. And so, the CT paperwork, was corrected, and now it was submitted to ACA December 16th?
16th.
17th. ACA has 60 days to review that and say, yeah, you can do that. So if they say, yes, the CT renovation room is a go, then they'll do that part. The generator there, we just making some tweaks with the architectural engineer and some paperwork there.
Right.
And once they say that's ready to go, you know what I mean, they'll begin to do that as well. So we're kind of hoping that the CT renovation can get started, you know, so we get the CT in, and by that time the generator stuff need to get hooked up, you know what I mean? It'll just be, you know, a seamless kind of transition instead of having one project stop and then another project's getting going. So we're trying to, hopefully ACA can begin to speed that up a little bit more for us as well.
Some of
But
the
it-
electrical has already been run. We've already got conduit down to the room.
Okay.
We have the wiring down to the room. It's just a matter of when CT gets going, then they can start hooking it up when they put the new equipment in there.
And I did give the deputy secretary from ACA, when she was here in December, I did give her a copy of our CT machine, equipment, what we're trying to do, kind of explain to her what we're trying to do, because all that comes under her department, basically. And so, hopefully we'll see some traction pretty soon, because I was telling the legislature yesterday about the rural capital improvement money, that this money is good, and what we would do with it, with the CT machine, because I say now, you see how cold it is. We have people, they have to go outside to get a CT
Awful.
exam, you know, how cold it is.
Wakes them up.
Yeah, wake them up.
Raises-
I make some grump, I make some grump until you get there.
I'm gonna tell you what.
Send them with a cup of coffee,
That-
right, Duffy?
That ride through them uneven doors and all that stuff like that,
I gotta get.
that'll wake you up, buddy.
And so-
My blood pressure went up 10
Agony
points
if you don't
from
feel
that.
good. That's just pure agony.
Yeah, so hopefully we can get that taken care of, you know, we'll see
Yeah.
some movement on them. I'm very excited about this.
Yeah.
I told somebody, you know, last year about this time that, hey, you know,
Yeah.
if you come back, you'll be in my office getting it done, but they're not, so.
Blood.
Yeah, the other thing ACA added too, they're always adding stuff, you know, and it's hard to keep up with them. I try to, but they decide stuff. They want the electrical engineers to add another transfer switch, and that's for the generator. Right now, the generator goes through 4 phases of transfer switches, and they want a 5th one put in.
What does that mean, 4 phases of transfer?
Well, what the transfer switches are is when, like, we run.
I know what that is.
Oh, okay.
What's 4 phases of it?
Oh, they want 5. Because you start up, and then you shut down some, then your next one picks up another area, and then you do your final shutdown. Now, I don't know what this 5th one is for yet. I haven't looked at all that information on that paper yet. But, yeah, and they had all 4 transfer stations put up, the hull, the boxes, and now they want a 5th one. And, you know, so, anyway, we got to do what they want to do and
Might as well do it.
move
Might as
on.
well do what they want
Yeah.
to do.
Are you haven't addressed, last time I saw you were over at the new EMS station over in Lanark.
Mm-hmm.
Are we responsible for any of that infrastructure over there?
I guess David and we talked about that, and I guess until we turn it over, I've got to go over there. I've got to go over there next week. Now that I've got Troy back, I'll have a little more free time. But I'm going to go over there and do that punch list for them. And one of my firefighters, Bruce, that works over there a lot, he said, I got a list for you. I said, well, I'll pick it up when I get there, because I'm going to install their blinds for them that's on the metal frames also while I'm over there. But yeah.
That's why I was asking.
Uh-huh.
Where's the punch list? Because
Yeah.
the men's bathroom doesn't have a lock on it.
Yeah, I know, it doesn't lock, yeah. And then your front door, the deadbolt at the top doesn't, you can't open it. So he said, oh, I got more than that.
Okay.
The bay door doesn't shut down all
But
the way.
that is our responsibility, or you just helping?
No, I'm just, Aaron said if I would make the punch list, and then they'll get Oliver Sperry to come back and do it, because it's under that contract.
Yeah,
I'm
you're just doing the punch list.
I'm just doing the
That's what
punch
you
list,
do.
yeah,
Okay.
trying to help out, yeah.
But now, when it's up and going, I think we're gonna keep the maintenance up on it, I guess, right, until the,
Yeah, until it goes over, sure.
yeah, sure, we need to.
Hopefully, we won't
need
have
to.
anything.
Well,
brand
yeah,
new building,
hopefully we won't
but,
have.
you know,
Does he mean when it goes over to the county?
Yeah. Yeah, it'll
And
be,
then they got the responsibility?
yeah.
yes, sir.
But they're not gonna come hire you to go do that?
No, they'll probably have their own people go out there and do that.
Yeah, they got county people do that.
Yeah, well, I guess we'll cross that road when we cross it.
It's gonna be close.
Yeah, I know.
A new building, so hopefully they won't have that many issues.
Yeah, I wouldn't think so. Yeah, but
Okay,
fingers crossed.
all right.
All right.
What do they need
Thank
to do?
you.
We're gonna do. That's it. I mean, if they need some help, we're gonna do it. And I know you will. I
yeah.
know you'll take care
Yeah,
of it.
yeah, that's-
You're working with
yeah.
Aaron on
Well,
that.
it's like I
but-
told James, I said, I saw the blinds sitting in the windows, and I said, well, I'll come over. I said, I got what you need to put them up with.
Yeah, good.
I'll take care of it when I come there.
Good.
Yeah, we'll do what we need to do.
Thank you so
All right.
much.
Thank y'all. I
Craig.
appreciate
Thank
it.
you
so much.
Y'all
We
have a great
appreciate
day.
you.
Let's see,
Don't get
today
too
you didn't
cold.
need but $22,000, right? That's all you need.
22,500.
$22,500. Oh, my goodness. Let's see, now we have the CFO report.
Yes.
Mr. Bowling?
Yep, we 20 minutes behind time, but
Yeah.
it's okay.
Way behind.
Yeah, let's get this moving, so.
How quick can he talk?
Spit them numbers, Bola, spit them numbers.
Well, Duffy, I'll try to get us back on track then, really quick.
Okay.
But, no, it'll take me a few minutes because, again, starting the new year or the new calendar year, of course, it's
That's
been a couple
okay.
months since
That's
we've
okay.
discussed the financials. So today I do want to mention and talk about, we are 3 months into the fiscal year. So I'll be discussing October, November, and December collectively to look at the 3 months together. But let me get stuff loaded up. Okay. So in your board, in your packets, I mean, you do see, like I said, you do see the November and December results in there. But again, I'm going to speak about it from a 3-month period and then also discuss some of the individual months' performances. But when you look at the first quarter, or the 3 months, as I just mentioned, of the hospital's fiscal 2026 year, the consolidated net income for the hospital did finish at a loss of approximately $600,000. That is as compared to a budgeted loss of $80,000 and a prior year loss of $466,000. Again, that's for the 3-month entire period of October, November, and December of this fiscal year of 26. Now, diving into some key, performance drivers and so forth that pertains to that 3-month period. When you look at gross pay, and again, I'm speaking from an income statement approach, starting from the top and walking down. When you look at gross patient revenue, again, that's chargeable services that the hospital provides. It did finish down about $594,000 or 12% versus our budget, again, for that 3-month period. However, was up $338,000 or roughly 9% versus the same 3 months in the previous year. So this time last year, compared to this time last year, we're up approximately $338,000 or 9% in chargeable revenue. When you look at the inpatient services, though, and I'm going to dive into the specific areas quickly, but when you look at inpatient revenues, we were down $148,000 again for this same 3-month period, with total patient days down approximately 15% versus budget. However, though, as mentioned earlier, I know Courtney touched on this earlier a bit, swing bed revenues, again, a strategy focus for the hospital. Swing bed revenues were up approximately $98,000, with total swing bed days up 4% versus budget and up 60% or 46 days versus this same time last year. So the strategy of bringing more swing bed related activity and patients to this community and to this hospital has increased, like I said, 60% versus the same period last year, or 46 days. The hospital's overall average daily census, I like to always mention this to the board and community as well. When you look at the average daily census, which includes observation patients as well, we did finish at approximately 2.1 if you do the math on it, but that means over two patients per day on average are staying within the walls of our facility. That is slightly down versus our budget. Budget was 2.2, so quite frankly a little spot on. But again, it is. I do want to call that out. When you look at outpatient revenues, though, we were down about $331,000 versus budget. As I speak about each time I'm up here, within outpatient revenues, we do have ER activity. That's where ER revenues is recorded. ER visits were down 258 or 21% versus budget, again, this 3-month period, and down 138 or 12% versus the same time or same periods last year. We did during this 3 months average about 11 ER visits per day, which is down compared to last year's run rate of approximately 13 visits per day. So, we're discussing and diving into what is the drivers. I know Dr. Conrad is not here today. Spoken with James. We've looked at the transports and so forth, and we're not seeing any change or any directional change from that standpoint. So we're obviously the clinic activity does offset some of that, but again, we're trying to dive into the drivers behind declines within the community related to our ER services. Again, that does have an impact obviously on outpatient revenues. It has impact on lab tests, x-rays, and so forth that are being performed here within the hospital. So with outpatient visits, we did finish slightly down. Again, visits outside of ER, we did finish slightly down 46 or 5% versus budget, however finished up 14 or 2% versus what we provided in the previous year. We did experience an overall, although x-rays, as I just mentioned, were down as ER activity is down, we did, though, experience an overall increase within imaging exams, which does include the CT scans, the ultrasound, and mammography. And as for the mammographies, the hospital provided 76 exams, which were up versus 51 during these same periods in the prior year. So we've seen some increase in swing bed related activity, seen increases within mammographies, CTs, although we've had issues and some delays within the CT, but I think getting the new CT, we can see we're seeing some growth within that area, which is great to have for the organization. Additionally, the chronic care management program did finish the month of December alone at 173 as compared to the trailing 12-month run rate of 149. So that program as well is seeing increases. So again, I do want to mention those because those, again, were services that were focus points for David and his team throughout the previous year, swing bed activity, mammography, chronic care, and so forth. So we're seeing some growth in those areas. Sorry, my screen just timed out, but so when we look at the clinics, I know Susie spoke, well about the clinics, but from a performance standpoint, we did see our rural health clinics did finish below budget by 30,000, collectively between the two clinics. Our visits, were down versus what we had budgeted, and but I do want to call out though that during this period, again, this 3-month period, you got to take into consideration the holidays that were involved with November and December. We did have our providers that were out of office, collectively combined, nearly 10 days out of office. Again, that does contribute to a decline, what we would experience within our activity, within our clinics.
In actual, right, in actual.
In actual, yeah, absolutely, in actual. And you know, but again, you know, allowing, it did allow though, you know, with providers out when they are out, and this was, you know, providers, you know, out at the same time as well. So it does limit the activity at the clinic as far as seeing actual, you know, patients and visits, but it does allow the staff and the team to be able to do needed things, needed projects that they needed to get caught up on and so forth within their clinics. So, you know, so they did take advantage and use that opportunity, having a little that downtime from patient care to get caught up on a lot of other activity within the clinics. EMS revenues, I mentioned the expenses earlier, but EMS revenues were down slightly, or about 10,000 or so, or 3% versus the same period in the prior year. You do see it down versus budget as well. But when you look at the total trips, billable and unbillable, they did finish those 3 months at 371 versus 380 in the prior year. So very comparable period over period. But I think the important part on the, you know, I mentioned the expenses being relatively flat versus budget and prior year. Revenues were down, and I think James brought up an excellent point earlier that with the flights increasing, you know, that does have an impact on revenues. Not so much on expenses, but does have impact on revenues. Obviously, their billable mileage has decreased as well, so that's why you see their revenue down, although their overall trips were very comparable year over year.
Actual.
Actual.
Okay.
Yeah, the comparison of
Because
actual
so far
performance.
what you have reported basically tells me, and I don't know if anybody else realizes it or thinks the same way, is that our budgeting process doesn't appear, our budgeting process needs to be fine-tuned.
Okay. Okay.
Because everything you've told me so far has been compared to budget, just about. And if the budget's set too high, we're always gonna look like, oh,
Yeah.
we didn't hit our mark.
Yeah. Well, and to John's point, that's why I am using the discussion versus the same period in the prior year as well. So I think that's important.
Actual to actual.
Actual to actual. That's a correct
And we're
statement.
down actual to actual for the first quarter as well.
Right. I guess that's what he
Yeah.
said so far.
Absolutely, yeah. Well, then I'll summarize it real quickly. You know, for the first quarter, the first 3 months of this fiscal year, yes, our consolidated net income is down versus actual to actual this 3 months period versus the same actual last year's 3 months. It's down. We have a loss of $466,000 down. Now, some key performance areas that have improved, again, year over year, and as I just mentioned, you know, swing bed, mammography, chronic care, and I do want to give a call out to the 340B program. The 340B program finished $130,000 better this year, the entire year actual, versus the previous year as well. So again, some of these focused programs, we're seeing growth, we're seeing improvement there. The challenges that we are experiencing, actual versus actual, is within our ER, and that does have a downstream impact, as I said, with lab tests, with X-rays and so forth being ordered. When you're actual in the past was seeing 13 visits per day, and now we're down to 11 visits per day within the ER, that decline in activity does have an impact, you know, core service. Yep.
The month of November in the ED took a big hit. That from like November 24 to December 25, it was some numbers lost on that.
Yeah.
But in the month of December, you look at December 2024, emergency room visits 351. December 2025, emergency room visits 352. So December kind of like stayed flat.
Yeah.
November kind of hurt us, and maybe the October area as well, though. When John was talking about the budgeting process there, as we move into the budget next year, we probably want to drop down some of our percentages on that budget. Because a lot of different things we look at and we shoot for certain things like, man, we can hit it this year, in which we did it last year like that in the swing bed area. But we probably want to look at that percentage, because I think we increased those percentages by maybe 5% or something like that, 4%. So we may want to budgeting wise, coming in the next year, look at that, as we talking about the budget, actual.
We put a challenge and opportunity in front of us, so, yeah.
Are we saying that we want to somewhat amend the budget based on first quarter numbers, or you want to leave the budget the way it is?
No, we leave it the way it is, and this next year, we just need to, and we may still hit certain areas in the budget, but this is just a good pivotal moment, the first quarter of the year, and we'll be going to look at that every quarter as well. But as we look at our budget and we discussing it, we need to make sure our numbers, maybe a little lower than what we projected this year, that's all.
Well,
And
we're-
to fine tune the
You
budget.
just don't want to get caught in the trap of thinking, oh, we're not doing too good because of the fact it's
That's
a
right.
budgeted number as opposed to actual.
That's right, that's right.
And the general public doesn't realize that. You say, it is, right?
Yeah, that's right. No, that's right. And so when you look at net patient revenue, again, this is what we collect for, what we anticipate collecting for services, and again, I'll mention too, budget, down 409,000 or 16%, but I think to John's point, and I'll certainly communicate it differently, looking at actual versus same period in the prior year, we're down slightly, only $22,000 or 1% versus the same period last year. So net patient revenues, again, that's what we expect to collect for those services. Actual is down $22,000 for that 3-month period. So it's pretty spot on from that standpoint. And those additional services I mentioned earlier has helped compensate and help with the declines we've seen within our ER.
What is the reason that we're trending downward in the actual area?
We're trending downward in the actual area, and as I mentioned earlier, the ER activity has been a big contributor to that. Although ER, and I know David mentioned those 3 months, but ER as a total, when you look at the patients we're seeing on average per day, and we're down to 11 patients per day seen through our ER, whereas it historically was 13. We're diving in to try to figure out what is happening
Okay, that's
within the
what I'm
community.
What's
to figure out.
triggering that? Is it the helicopter service? No.
No, and I mentioned this earlier too, the transports, we're not seeing any change in mode of transportation of arrival of coming through the ambulance services. The EMS trips are nearly comparable, 380, 371, actual to actual. Their transports are not, still getting the same complement.
So
Again,
we
there's
should
no
take
new
credit
clinic.
for improving the health of the community.
That's our focus, right? To
Right.
improve the health of the community. But ER, again, ER is an emergency visit, right? So the emergent needs of patients coming to the hospital has been down.
But
And
if
so,
you're- if
so
you're-
we're, yeah,
Communicating
yeah.
good health practices and taking care of, you got less visits.
Well, I mean.
Only the real accidents are gonna show up at the ER.
Right, and then you're gonna see your acuity within your ER.
Well, you really want, to be honest with you, you really want to make sure that people really don't use the ER like a primary care clinic,
No, you know
basically.
better than that.
That ain't gonna happen.
That ain't
But ain't
gonna
gonna happen. I know in small communities,
Did it myself yesterday.
Yeah, in small communities, and so, the flip side, we can say, yeah, we are, the messaging about, being healthy, people are staying out of the ED, which is good, because we really don't want people, we want people to be healthy, but we know this is a business as well. And, I can't put my finger on it, basically, why the business are down. I just know in December, they were flat.
Yeah.
November was bad. Now we need to see how January looked, from the January point of
That's
view.
it.
Yeah,
That's it.
absolutely. We're gonna follow these trends. We're diving into, we're trying to figure it out. Like I said, we've
You're
talked
talking
to
about 2
EMS.
patients a day.
2 patients per day.
Yeah.
Them small numbers mean a big percentage, though.
Those small numbers mean a big percentage
So
because those small
it
numbers
gets
do
difficult
drive.
when you're, of course, 2 patients a day is 60 over a month.
That's right.
Yeah, Courtney wants
But-
to say something.
I don't know that we can put our finger on this,
Right.
What's the good thing is, we've got other revenue flows.
That's right.
That we don't have to totally depend on the ER.
That's right.
That's a good thing.
And to your point, Chairman, what you just stated there, that's why when you see net patient revenue, again, what we anticipate collecting for services, is only down 22,000 year over year, or roughly 1%,
see, that's-
because the other revenue areas, the swing bed, mammography, ultrasound,
Exactly,
CTs,
exactly. We don't
340B
we
program,
don't
these
depend.
programs are
We-
helping.
We've got so
That's
many, every revenue source
Yep.
will help, and we don't live and die by ER, so that's,
Being down your ER, you know, and John has asked about as far as the contributions to loss. Yes, it will, because you do have staffing, core staffing, you got providers, you got care that's got to be available, and you know, so it is a challenge when you see declines there. We're trying to get a better understanding so we can have, you know.
Well, I guess one of the questions, since we got James in the building, is do patients direct you as far as, I want to go to Sacred Heart versus Weems?
no.
They ask, occasionally we'll do it out of courtesy, but majority, as I showed him,
Yeah.
majority of our transports from the War II Weems.
Yeah.
Realistically, we cannot determine how many people that are going to show up in ER.
That's right.
That's what I was
Realistically.
That's right.
I know,
So
we're beating
I
this.
understand you said you're trying to find out.
Right.
And all that, but the bottom line is, we don't know.
Right.
Because we don't know when people are going to, nobody knows when we're going to be
We
sick
have an emergency need.
and have to go. So basically, we can kind of put this part to bed.
Yeah.
Yeah, I mean, that's,
Well, unless, also, Ms. Kroom, unless we have a customer service issue, you know, in our ER, which we have to continue to look at, you know.
Right.
I mean,
Yes,
look
yes,
at it.
yes, yes, yes.
If the public doesn't feel comfortable coming to Weems,
Yeah.
if we have a PR issue, we have a service issue, they may be directing themselves to another hospital.
There's plenty
It
of people
doesn't
that
have
drive
to be
themselves
through
to the ER.
EMS, it could be they drive themselves,
Somewhere else.
and that's where they're going to go. I think what we have to really focus on is we have to focus on our PR here and make sure that we get out that we are responsible, we're the best option for the local patient to come to. And if we don't put that PR and we don't get that social interaction with the public, and we don't change some old perspectives, we're going to continue to have an ER issue. And as Mr. Bowen had indicated, and I agree with him, that your your ER is going to funnel down patients throughout your system, whether it's labs or X-ray or whatever it is, that those are going to be ancillary services that we're going to be cashing in on as a patient comes to us. So we can't ignore the ER.
And like I said before, if you look at
No, it's our baby.
December 2024 and December 2025 number, you're looking at one. You know, we were like one patient down. And so now, as we look at January's numbers, look at February and March numbers this quarter here, and see where we at then. Because if you just look at, you know, it was flat those particular years. So the ER issue was totally going in the opposite direction. That December number would have been going low too, as well. It wouldn't have been just flat, you know. So
Yeah, I get what you're saying. You need large numbers to determine the direction of that percentage drop or rise. But certainly you want to make sure that we do everything we can
Oh, yeah.
to
Of
bolster
course,
the
of course, nobody's
the
saying.
community's perception of us.
That's right.
Oh,
That's
yeah.
right. We're going to
Oh, yeah.
focus.
And
We're going
that's ongoing.
focus.
you know,
Yes,
and that's an
of
ongoing
course.
process. That's just not.
That goes without saying.
Yeah, that's nothing new. This is ongoing. You know, we always got to continue, and of course, I have the director of nursing here also. You know, we got to continue to, you know, emphasize our ER. We got to continue to, you know, push the ER. You know,
You'll be seen by a doctor,
the
too.
receptions.
You will be seen by a doctor.
Yeah, 24 hours a day.
Dr. Conrad's got how much experience as an ER doctor here? How many years?
Yeah, many years. Yeah.
And the other
He's
doctors?
like an old MASH Navy or Army doctor. He's just been around the block.
I mean,
Who said that?
so I think a little
He can fix
advertisement,
anything.
highlighting stuff like that. We about beat this to death, y'all.
Yeah,
I mean,
we
need to
can
look
go on,
at
but we
this
definitely
number.
do the PR.
Yeah.
Y'all are, you're looking at that, though, right?
Absolutely, absolutely. So,
Yeah.
and I want to mention on expenses, just, you know, because I talked about some revenues being down, but, you know, look at hospital operating expenses as a total. You know, we're down 168,000 or 5% versus budget, down versus same period actual. Personnel costs, when you look at salaries, wages, benefits, as well as any contracts, we're slightly up versus our budget. Management is looking at labor productivity and monitoring a labor productivity tool that's in place and reviewing those areas. And again, reducing as many ways as they can within premium labor. Certainly EMS is still rolling up in those numbers as well. James has had some challenges. He mentioned that earlier during the month of January alone. So that is going to drive up some of that premium spend as a whole. Professional fees below budget though. $62,000. Additionally, supplies are below budget as well. $70,000. Again, supplies. I want to keep calling this out. That supplies includes pharmaceuticals. I think we all recall we did include a reserve in the budget process for the retail pharmacy that we're planning to look at for the Carabel Clinic location. We do have and have completed and updated that study. I do look to try to work with the board and David next month of bringing that back to the board as far as that updated numbers with that retail pharmacy so that we can look to move forward with that as well. Just again, just to summarize this in total, again, for this 3-month performance, and this is for the public and certainly for us here in the room, we did finish at a consolidated net income loss of $607,000 on a budgeted net loss of $81,000, but falling short of budget of $527,000. That's versus our budget. Some balance sheet cash flow related comments and how this incomes move into managing the cash position for the hospital. When you look at cash position, it was certainly is impacted by slower patient volumes. When volumes are down, that does impact our cash. The hospital's days cash on hand did finish at approximately 48, which is down from 64 in the previous month. But patient AR activity continues again to be a strong focus. Did finish December at 79. That is comparable to that run rate, that trailing 12 months, or the same 12 months average is at 78. So it is very comparable. Now again, within those days, again, I always want to call that out, that we do have a high proportion of private pay, uninsured, self-pay related AR, and that's a challenge. That's always a challenge to collect from patients that do not have commercial-based insurance. We're working diligently. TrueBridge is our third party that helps us. David has recently moved the bi-weekly meetings they were having to more of a weekly meeting now to try to put a stronger focus and address any concerns, any issues, anything they're experiencing with these slower cash flows. But again, just try to put more direction there as well. Again, you have a revenue cycle dashboard that's in your packet. It does have some KPIs, so you can see how that's being measured and monitored compared to those. Other current assets, and I always want to call this out to the board and the public, make everyone aware on the balance sheet. There is approximately 1.3 million related to state dish and lip receivables that we do expect to receive the cash at some point as well. The hospital does continue, from a liability side of the business, does continue a very manageable process with our accounts payable. Do want to thank, the finance committee. I think the finance committee meeting and reviewing these payables and so forth, I think has been extremely helpful and beneficial. I think bringing awareness to the board and to everyone involved with that process. So I think that's gone really well. We didn't see AP, again, there's no vendor payables or anything at risk within the organization. We did see our disbursements that didn't fluctuate too much month to month. December disbursements finished at 532, November was 482. So those numbers are very comparable. When you look at our vendor payables and you see accounts payables on the balance sheet increasing, we do see those increasing, and it is primarily due to the, now with the new arrangement that we have with our ER providers, right? We are now paying them versus paying a company. So that will drive up, and I think that's part of the finance committee as they're reviewing that, do see that activity now. Lastly, or just a couple other just quick notes, just for clarity purposes, We do have, David mentioned this as well, the Rural Hospital Capital Improvement Grants. Those do get pushed into, again, liabilities because those grants have obligations that's got to be met to be able to release it out of a liability. Craig and David have talked about the CT project. We're using the past couple years of grant monies that came in to do that. It is on the balance sheet as a liability. So when folks see that, just want to always bring attention to that. As this gets built out, put into service, that liability will be relieved and be able to be moved out of that status. Capital obviously is very minimal, mission critical, no new long-term debts or anything entered into for the organization. And last comment I do want to make on the balance sheet, just to bring a little clarity, you'll see a comment that says GASB 87. I had someone ask me before, what does that even mean? Why is this even on there? GASB, and this is again for all of us and public, if they're listening, it's the Governmental Accounting Standards Board. That's what GASB means. It's the acronym for that. It is a source of GAAP, or generally accepted accounting principles. And I'm getting pretty technical, but I just want to bring some clarity because I was asked, what does that mean on there and why do we have that value? In essence, in a nutshell, it requires the hospital to recognize lease liabilities. So whether it's operating and or capital leases, there has to be a right to use lease asset and liability that gets established. It's the Accounting Standard Board's way of eliminating operating and capital and combining it and making you park it on the balance sheet. I know it probably sounded, hopefully that explains some of it, but I know the audit firms typically go through that in detail when they talk about the audit process. But I wanted to put some context around that just because it has that line item there, and I've been asked, what does that mean? And then, as I just mentioned there as well, the audit is nearly complete. I think Brian Hall, you guys have all met Brian in the past, the audit partner with Carr, Riggs and Ingram. There's a couple of items that they're wrapping up. I know Kevin Ward, his team is wrapping up a couple of responses to them in regards to some IT controls that they were testing, and then there's obviously the cost report related activity that will be based on the previous fiscal year they'll need to record in the audit. Those are only a couple items I think Brian has left. I think he's anticipating being able to present the audit next month based on the previous fiscal year. So I know they are wrapping that up as well. And I know I just mentioned a lot, but open for any questions, any other discussion? Or?
Got a question.
Yes, sir.
The monthly revenue cycle dashboard.
Yes, sir.
What is denial management metrics, like timely filing, denials? I mean, I don't quite understand that.
Yeah. So when you look at that denial management metrics, so when you bill for services, and Susie made a good point earlier. You're going to get paid from a vendor, whatever you have, or from a commercial-based insurance, whatever you have contracted to get paid for. And then the other portion of it's going to be what is termed as a contractual adjustment. Mm-hmm. Additionally, though, there are additional adjustments which would fall into the category of denials, and these are the categories that are typically part of what an overall denial is. So you can have denial for timely filing, which means the claim wasn't filed with the contracted payer within their timeline. So I'll give you a great example. Medicare, for example, governmental based, is typically you got 365 days to file it, right? Typically it's a year to get the claim, processed and adjudicated. But there are some payers that have a 90-day window to get the claim that, through their processing, or they can deny it for timely filing reasons. Medical necessity, I think that's kind of self-explanatory from that standpoint. You got prior authorizations, which is a challenging spot, because that's a spot where you do, like a better word, you're arm wrestling a lot of times with the payers. Mm-hmm. Did you have a prior auth or not? And for a particular service that they say maybe shouldn't have been inpatient, or shouldn't have been an observation, should have been this, and you're going back and forth, and they will deny it they being the payer, they will deny it for that very reason, and you still got some appeal rights and so forth, and you try to challenge that and go back and forth with them.
Do we challenge it? Do we go back to
We do.
them?
We
Yeah.
challenge all of that to ensure, did we have the authorization or not, and/or was it appropriate and so forth. So these do get addressed and do get
I mean,
challenged.
1 month, total, that's total.
Yeah, and again,
Okay.
this
3
is,
months,
this is
95.
also the charge too, so kind of keep that in mind too. This is, so on a, again, so what you charge for the services versus what you ultimately contractually get paid for the services, this denial would be based on the overall charge of
Okay.
that service. So if a patient had a $1,000 charge, and contractually we were due to get $250, but it was denied for whatever reason, that $1,000 is what rolls into this category, because that $1,000 has to be adjusted off because it was denied.
And this is something that we talked about with the, a couple of the representatives about this, some of the hospitals, because a lot of hospitals are saying the insurance companies playing games, especially with the claims. They reject you, you have to resubmit, they reject you, resubmit, then when you go past the timely filing date, you can't get paid. But Representative Dean Blake, we met with him yesterday, he has an insurance claims payment to healthcare providers bill, House Bill 1023, that hopefully will address some of this stuff with the managed care companies that we have in the state of Florida. So that's going to be very important, because CEO after CEO begin to share stories about how the insurance companies are playing games with these timely filings and denials, and then sometimes you can't get paid because then you pass that date there. And so hopefully the bill that he's have now hopefully get passed, and then it brings some kind of issues. It would deal with issues and bring some kind of accountability to these health plans here. So, so I think
Yeah,
that's a good bill.
if they deny it and shouldn't have, they should be fined.
Absolutely.
Yeah.
Fine them,
Yeah.
a hefty sum. Now, if we don't file it
Yeah.
timely,
Yeah.
that's on us.
Yeah, that's why we meeting. That's why we.
Why are we not filing time?
Yeah. I mean, there's going to be
What would
various
cause,
reasons.
give an example.
Yeah,
It's $3,000
yeah.
for this month. It's
Yeah.
really improved
I
from.
mean, examples, I guess, John, would be just whether they had the insurance right in the first place, or there was delays in a front-end process of a registration and getting incorrect information from a patient and/or populating, again, it moves it, further down that path. And again,
Okay.
particular payer usually has those stronger or tighter windows. That's when you run that risk.
Okay.
Now from an overall standpoint of, you see 95,000 as compared to our chargeable revenue, that's just under 7% of our chargeable revenue. We would want to best practice try to target that. You're going to have some level of denial.
Yeah,
You're never
sure.
going to be clean slate.
When
We
they're
would want-
denied, do we get a copy of the EOBs of why the denial
Yeah, you
was
get the
there?
reason, you get the reason code, and these are categories of those reason codes. There are various reason codes and these are just rolled up under those categories.
How many have we ever done, let's put it that way, have we ever looked at it and made an analysis as to, are they coding errors on our part? Are they out-of-date filings? Are they,
Yeah.
and I thought, and maybe I'm wrong, I thought TrueBridge did our coding. Who does our coding?
Yeah. Well,
Yeah.
TrueBridge handles the revenue cycle billing. And
Yeah,
so
yeah,
forth.
and they have a. and they have
So,
Yeah.
are the errors
Yeah.
TrueBridge errors, or are they our staff?
No, and there's various activity there, John. Again, and they have a pretty comprehensive report that actually details that out. That's what when I
Who is
referenced
they?
they being TrueBridge. So when I referenced that earlier about, when I referenced that earlier, David has, and again, I think he's done a great job with this. He has now requested to have weekly meetings with them to walk through any of those trends or any of those issues that they're seeing they may have concerns with, so that we can address it here if it does pertain to issues here. So, to kind of put this more into context, when you look at manageable processes, we had roughly 1.3 million in the month of 1.3 million in chargeable revenue during the month of December. Yes, we had 95,000 in denials. Yes, that's approximately just under 7% in denials. We'd want to manage that down to 2%, 2 to 3%, and that would be a best practice approach. but again, given the numbers and one or two will push, an issue with the prior authorization, as you can see in these metrics. That's why we want to bring attention to it, because David brought up a good point. One prior authorization claim like that we have a challenge with a payer can significantly impact that percentage. And if that gets overturned, then obviously it helps us.
Yeah.
But those are always being addressed.
Yeah,
I'm sorry.
yeah, we're addressing, I think Heather addressed it, I'm sure they'd be on phones on a daily basis, really, about, different things need to be coded, what should be changed. She does that on a daily basis.
Yeah.
Weekly now, we'll meet with the TrueBridge team, we have different categories. I may ask a question, hey, these denials, is it because the registration error? Or is it because physician had put the right
So
code
you're
in?
addressing this, you're addressing this.
Yeah, so we're addressing it. And-
What would your target be, 3%, 2%?
2 to
Yeah,
3%.
2%, which is good,
Okay,
because,
good
a
practice.
few years ago.
And
we had-
what is it now, about 7?
Yeah, it's just under 7
Yeah.
for that month.
Yeah, for that month.
Yeah, for a month, yeah, okay.
Walk me through quickly, how do we have negative numbers in this denial?
I don't understand
That's
that.
getting overturned, like I just mentioned.
Okay, the
it's-
overturns, okay.
Yeah, the overturns.
Oh, okay.
So
Okay.
having that
There you go.
situation,
Okay,
yeah.
I wondered why they're negative. I was scared, I was ashamed to ask.
Well, the reason, the reason code.
No dumb questions.
That's them going back and forth and getting things cleaned up. I mean, again, these are the reason codes that get triggered for this particular month, and then next month, if it's fault, it'd be reversed back. So that's got to get, you'll have your ebbs and flows and back and
It
forth.
looks like we did pretty good in October on that.
Sure. Yeah. I mean,
Should we make this, let me ask this of the board, should we bring this in as an analysis in the finance committee to look at it?
Yeah, that'd be a good idea. The finance
Good
committee
point.
can look at this too.
That's a very
Yeah,
good point.
Sure.
Yeah.
Absolutely.
I think it might put a little more light on it. Let's find out where these errors are coming
I
from.
think that, well, they're addressing it with
Yeah.
weekly meetings instead of bi-weekly. I think you're gonna find out TrueBridge about to have some
Yeah.
problems there.
Yeah, and we were meeting with
Put it as
TrueBridge every
line
week, but we got, we were doing better, just,
Just to get better.
we just
Yeah.
figured, okay, we'll move it every 2 weeks. So now we're going back to a weekly meeting with them.
Yeah.
And
Okay.
we have that meeting, and we talk about a whole lot of different things during that meeting with TrueBridge, about this, but,
And
we
you're
can
gonna-
address it during the finance
Yeah,
meeting.
yeah, and
All
from a
right.
presentation standpoint, I mean, you're gonna see this, we're gonna trend this revenue cycle dashboard out. I mean, you're gonna see, eventually, you're gonna see a full 12 months of activity here. That way you always have that visibility for it as
Okay.
well. But
You're
I would
addressing
take it to the
fine,
finance
fine.
committee. Yeah.
All right, let's move on now.
Yep.
Go ahead.
That's all I got, unless there's any other questions or comments related to the performance for the past 3 months.
Thank you.
Yes, sir.
Thank you.
Yes, sir.
Anybody got anything
Your
else?
presentation was great.
Thank you. Thank you, sir. Appreciate that.
Thank you very much. All right. The next item is,
Well, you have Bill right under there, Duffy.
Bill.
Yeah, finance.
You're gonna look over me again, huh?
No, the CEO report. I'm sorry.
No, we got Bill.
I missed the CEO report. I gotta start checking.
All right. Finance Committee, we met twice. Meetings were on the 8th and 16th of January.
Yeah.
We did look through all the accounts receivables. We looked at the voided checks. We looked at what's going out. We had no issues with any of that. In particular, we did also discuss, and it was an ongoing discussion, about sponsorships that came up and whether the hospital has an ability to directly sponsor sports programs or other nonprofit programs within the community. And I think we did address that with the board. I think, David, you have some more information on that?
Yeah, and what I did, I sent a message to Michael Schuler. Well, Jason Bonner first talked to Brian Hall, the auditor, and the auditor wanted us to get guidance from Attorney Schuler. What would the county recommend for us to do with these sponsorships? Because we sponsor, community organizations, for example, Carabel Cares, the Pink Out, MLK, H. Cola. So we do different sponsorships, Seahawk Booster
That's
Clubs
true.
as well.
Yeah.
And so, they would talk and then get back with us on that. But Also, it may be best for us to see, can we develop a policy, look at Alliant hospitals and see if they have any other policies that have on sponsorships, and then get that information to Shula and let them look at it as well. But it's all about, not being in conflict with the county. If the county sponsor a group and then they come to us, if the county reject them, and they come to us to try to come back to us to get sponsorships
That's
like that,
right.
which we hadn't had that happen yet, to be honest with you.
But the county sponsors people, right?
Go ahead, John. The county gives donations to like Little League teams when they go to
Yeah.
state.
State or whatever.
The World
Big
Series.
things, yeah.
Yeah,
Same
this is
thing.
mostly.
It's the same thing.
Yeah, this is mostly we do it as a community benefit as a hospital.
Right.
I think the real question, though, is can we do it out of the hospital trust fund as opposed to when the county's bringing them all in and awarding them once a year, whatever is necessary, and they're explained, and then the county makes a decision on these type of grants or whatever we want. Should we be using hospital funds for that type of purpose? That
It's
was the
good,
real
great
question.
advertising. I mean, it's just advertising is what I'd call it almost. But, well, you're gonna find out from Mr. Shooter, right?
Yeah, but the thing also that we probably need to do, we could also develop a policy, and say, develop a policy, let the board review the policy as well, and just give it to Shula, maybe Shula.
Get
make a-
Alliant to do the sponsorship. How about that? All right.
Let's get going now. Go ahead, David.
Yeah,
We're
and
running
so
behind.
and so the other idea was that,
I
maybe.
mean, somebody brought, let's get the foundation to do
Yeah,
it. No,
yeah,
let's get Alliant first, and then maybe we'll go to the foundation.
Yeah, maybe.
All right, but John, I think the hospital has to show a good community face here. And we need to put money where our mouth is and make
Yes.
sure that the community knows we're out there to service them. And quite frankly, if you want to say anything about Alliant, they were a big fund provider for our foundation gala.
They were.
And put out
Wonderful.
$2,500.
Wonderful.
So they do contribute, sir.
They also didn't even hesitate when I reached out for the water crisis. They
so-
sent me a semi truck full of water. They didn't even hesitate for our community.
So you don't want me to suggest charging them, right? Get them to pay.
Why don't we just split it 50-50 with Alliant?
Yeah, but the sponsorship is essentially telling our community, hey, we're part of this community.
That's
You know what I
right.
mean? Think
Yeah,
about
you
it.
want the Weems name on it. I mean,
Yeah.
quite honestly, if you put a lion on a baseball or football banner,
They're gonna be
nobody
like,
knows
"Who's
who that
that?"
is. You need Weems' logo there.
Yeah, who's
Put
Alliant?
liens on there, we would just.
Well, you can
give them
take that
the
up with
money.
Michael Posar.
So what Barry's saying is
Let's move on.
Alliant's gonna
David.
fund it, but we're gonna brand it.
Hold on, let's
That's
move
a
on.
great deal for Alliant.
Yeah, so
David's
we'll-
gonna, David's gonna check
yeah, so we'll get more
Shooter,
information.
see what we need to do.
Yeah.
We're gonna get a develop a policy. Next subject.
Okay, next subject.
Mr. Barry likes to stir the pot there, doesn't he?
I don't mind.
So that's one thing we're looking into is the charitable giving, and I think we should have a specific budget for how much we can
Absolutely.
provide out to the community out of what we our revenue stream, et cetera. I think it's important.
I agree.
I agree.
Second
Sounds great.
thing on
Sounds
here
great.
is, we did talk about MultiView. Now, that MultiView is the financial software program that we were looking, we approved to install. And I think it's been going back and forth a little bit between the town attorney, the county attorney, and MultiView as far as the language on the termination of the contract and what termination provisions would be amenable to both parties. And I know that, maybe you have more information on this than I do, David, or more updated information.
Yeah, so what happened, we went to the county commission to get the multi-view contract approved because there were certain things in there. And then the county commission wanted us to add, of course, a termination of convenience in that language with multi-view. Multi-view say, well, David, this is a one-year contract. We really don't do termination of convenience. And so I told multi-view, well, why don't you go back and think about that because you're looking at a partnership here. And so now, they're talking with their legal team to see if they want to accept that language of termination of convenience. If they do not accept that language of termination of convenience, we probably won't be able to do the contract with them because that's what the county commission recommended. So we may have to look at other alternatives. So I'm waiting on multi-view to get back with me and see if that language is, agreeable to them.
Great. I mean, the sooner we can get that installed, the better, I think, because it's a great contract and a product that we could really use. That's pretty much all I have for the Finance Committee.
Okay. Anybody else got any questions? Okay, let me, I've got out of order so bad here today.
Yeah, I'm gonna get you back in order now. We coming.
Now,
Happens.
well,
Okay.
We just
David,
hour,
how about you give me,
we just hour behind, but we'll get.
My stomach says no.
Awful.
give me a report.
Okay, let me give you my report just quickly. Florida Rural Health Transformation Program event recap. Remember last, well, in November, we were talking about this new money coming out of the federal government. You know, and then somebody would say, hey, we need to be at the table with that money. And then right after the meeting in November, I got a call from the deputy secretary saying, hey, David, can you host this meeting here with ACA? So we hosted a meeting in December. You know, for people from over the Panhandle, they came. Of course, we had some board members there, you know, asking a whole lot of good questions at that meeting about this new funding. And what it is that the federal government has given Florida money. The money has not been allocated yet. ACA is doing an RFP. The RFP has not been allocated yet. There are 8 hospitals that are joining together as a collaborative, you know, to try to submit an application together so we can be considered more strongly processed. So it's 8 of us coming together as a collaborative for that. Right now, the agency's still trying to answer some questions around this money. You know, they got some questions that they probably want to clarify with CMS. So right now, you know, there is no application out yet for it, but we're just banding together as hospitals for that.
But David, just make it clear that there are other people beyond hospitals looking to vie for this money. So we've got a lot of other players that.
There's a lot of there's a lot of other players with this. We were talking with the legislator yesterday, and he said he had told ACA leadership, you know, to make sure that this money stays local, because he said, hey, I know you're gonna have a lot of people coming in from outside. You know, right now, I think all your rural hospital CEOs are probably the most popular people now in the state, because we get a lot of calls. You know, hey, I want to come partnership with you. You know, hey, I got this. You know, of course. And so we're banding together.
Which 8 hospitals?
We have Doctors Memorial in
Taylor.
In Taylor. We have Medicine Hospital in Madison County. We have Jackson in Mariana. We have Calhoun Liberty. We have Northwest Florida. That's Market Kozar. We also have Doctors Memorial in Bonifay. You know, they came to the table. And I think Baptist Health has come also. So most of your majority of your 8 rural hospitals in this region is coming together as a collaborative. Yeah, which is
It's
good.
us against them.
That's right.
So we should get a report every month as to what that group is doing.
Yeah.
Where we're at.
And how are the projects or the requests within that group going to be measured and decided as to who's got priority?
Yeah, so what happened is, like, the group, you know, there are 15 initiatives, so we're not going to try to do all 15 the first year. So the top 3 initiatives would be, you know, your rural health clinics, workforce development, and specialty care. You know, those are the top 3 that we've been discussing, that, hey, this is what we need to look at first. And of course, we got EMS as the community paramedicine program, so they'll be included as well. But those top 3, you know, areas that we'll want to focus on, because all the rural communities don't have specialists. You know what I mean? So you'll need that. Workforce development, what we're talking about that is that for these areas like your medical technologists, the lab departments, a lot of people having a hard time filling lab positions and things like that, or respiratory therapist positions and stuff. And then the rural health clinics, satellite clinics. Can we increase our clinic exposure here? You know, the grant right now, and this is concerned, you know, that I spoke to FHA to relate a message back to ACA, which I talked to ACA about this as well, is that the grant now doesn't allow me as a rural health clinic to really expand my clinic. You know, it allowed me to go partner with a physician office in Tallahassee or Panama City urban to come here, you know, to do that, or it will allow a nurse practitioner, you know, for example, just say Kristen getting her license and she want to open up her own facility, you know, this money would allow her to do that, you know. But it really won't allow us to expand. So we're trying to create some avenues that the money would allow us to expand our clinics there. And then the flip side of this money as well is that you got to be self-sustainable.
Yeah.
You know, after 5 years, you know, you got to be able to continue with these particular programs. So you really don't want to do anything that you might not have enough money to sustain it.
That's right.
Right.
And so I'll give updates, you know, on a monthly basis of what we're doing with that.
Wonderful.
Secondly, FHA legislative days, I've been talking about that a little bit more. You know, yesterday we met with representatives in the House, you know, about our different priorities. There's a rural renaissance bill. There's a category in there to raise the Medicaid reimbursement for critical access hospitals, which would help us out. We also told them, you know, to continue to thank them for continue to approve the recurring dollars of the capital improvement program, monies that we get here to do these improvements at the hospital. And then one of the main things we talked about is payer accountability with Representative Dean Black bill, you know, to make these insurance companies, you know, more accountable to these issues that we're having with insurance claims payments and healthcare providers. The Press Ganey survey, I just want to tell you this. I don't know if y'all read Alliant press release that they sent this out. They have Weems mentioned. You have the Press Ganey is a survey that Alliant does every 2 years. I put this in your packet. And so Weems' score was a 4.43, but just to read something quickly to you, it says that 768 members of the 1,200 personnel contributed to the survey findings demonstrated a 64% response rate. It has that Alliant Management Services proud to congratulate George E. Weems Memorial Hospital in recording a 4.43 engagement score, well over the national mean, in which 91% of their respondents reported engaged or highly engaged. A sense of belonging and ability to recommend the organization as a great place to work were two of the highest indicators of staff engagement, according to the survey. And so Weems scored the highest of all the line hospitals, you know. And here's a survey here. And so that's a great job. Y'all can hand up to staff, you know. That's a great job, you know, for the staff here, because you know, staff tell you how they feel anonymously, really. And now 2 areas, you know, there's a lot of different areas that we score well on. You know, I feel like I belong to this organization. I'm satisfied as an employee. I will recommend this place to work, a good place to work. The person I report to gives me useful feedback. The person I report to encourages me with team respect and teamwork. And then we know there's 2 areas that we definitely continue to work on, which we got the 2 lowest scores here. And we had a 56% score, which was our lowest, is saying that my pay is fair compared to other healthcare employees. So we know we have to continue to work on pay, which we've been doing that every year. And then the organization provides career development opportunities, so we have a 72% there. But all other scores was pretty much in the 90s, 80s, high 80s, and 100%, you know, for the organization. So, you know, staff did a great job. I've sent this out to all the staff as well. I even mentioned this in our December luncheon, you know, with all of our staff there about, you know, hey, we hear you, because many times, you know, they'll tell us what they want, but then if we don't do anything about it, then they don't want to do these surveys. So we try to like say, hey, this is what you said, you didn't like, this is what we're doing, but here's some of the good things that you're saying about your organization.
What's the bad thing?
Well, my pay. The pay is
So
bad.
we need to,
Which will be there every year. I don't care what organization it is, it's gonna be there every year.
well, hold up, that's not necessarily true. There are hospitals that pay more hourly when you have a bachelor's degree as opposed to an RN. There are hospitals out there that do tuition reimbursement, so we can't discuss that today, but I think we definitely need to discuss that for our employees.
Yeah, and what I told
They deserve more money when they have a higher degree.
Yeah,
That's just the way it is.
And here's the thing too, when I told the employees, you know, when I started, there was no raises giving, nothing here. And so every year I say, you know, you eat an elephant one bite at a time. We did a salary parity here, and we did that a couple of years in a row. And then we begin to do these incrementals, you know, 4% increases, you know. So that's something that, you know, we'll continue to look at that, you know, as the revenue grows, we'll continue to look at that for our staff, you know. And then, you know, career development opportunities, you know what I mean, you know, have a trike for certain staff if they want to move in, say, you may have a front desk person may want to move in an accounting role, or may want to do some fiscal stuff.
So cross-training.
We don't have
Cross-training.
turnover. We don't have turnover, so that don't. that-
Yeah,
that-
yeah, but they may
that's-
want to increase their knowledge and their abilities, so we want to give that opportunity, give them the opportunity there. So we had about 2 out of a whole bunch of things that, we had 2 negatives and a bunch of positives, but you still got to address the negatives with the staff, so that's why I did this survey in front of the team. I say, this is what you did, and this is what you said that you want us to improve on. And so we'll continue to work at that on a consistent basis there. So I thought that was pretty good there.
Do we do sign-on bonuses, Courtney?
No.
No.
Do what? I didn't hear you.
Sign-on bonuses for new nurses or new staff, sign-on bonuses.
Yeah, and so you look at that, you also.
Something we can talk about later.
Yeah, and not only nurses, but you look at your lab, you're hard to
Right.
get
Yeah,
people,
we got-
you know what I mean, your providers. And that's something that, we definitely look at as a board. We have some categories, and we can take a look at some of the other line hospitals.
Yeah,
and
you
see
can do
what
something
kind
like
of
moving costs as well. I mean,
Exactly.
Yeah.
that's something that's in there.
Yes.
That's a huge barrier for our community, you know that.
Yeah.
For teachers, for
Absolutely.
providers, for
Yeah.
the
So
whole.
we can look at some of our other line hospitals and see what kind of structures they may have and begin to implement that. And that'll help out with that.
I'm gonna hold you to that, Walker.
Yeah, well, we've been doing it, so we'll do it.
Well, yeah,
Oh,
always
I'm
gotta
gonna
remember.
advocate for my nurses.
Not only your nurses, now you gotta advocate for everybody.
With my heart is my heart's with nursing, you know that.
What about the person that works cleaning the rooms too? We
Right.
gotta- That's, but we gotta remember now, we got X amount of money to use too. I think we need to continue working with raises for everybody. If there's some extra stuff that we can do, but we gotta be a little careful with that too.
Right.
You know, we
All right. All right.
gotta make some money,
Okay, I already talked about I know I got to move on. The generous donation was good. I want to give a kudos to a fraternity, which is probably the greatest fraternity in America, all over the world. Omega Psi Phi fraternity.
Oh, my.
Omega Psi Phi fraternity.
Yes.
Which is my fraternity.
That is right.
You gonna do your little stuff
all
down
over the
there?
world.
I remember them. Y'all do that. You gonna do some of that little, what do you do, this right here?
Yeah, well, just look at Michael Jordan, you'll see him.
What do you do now?
But one of the things, the reason why I'm saying that is that, the chapter out of Tallahassee, last year they donated toys here. They called me and said, hey, David, we're doing a toy drive in Tallahassee. Do you need any toys, for your community? And so, just so happened, I told them yes, and then we had a member in the community, the house burnt down, and so the kids right around that time last year, so we were able to give them some toys as well. So they called me again, and this year we partnered with a local daycare, to have the needy
Good.
families come over and get these toys. So that's my fraternity, Omega Psi Phi
Yes, sir.
fraternity. So I want to just give them a
What's their
kudos.
fight song?
I don't think they
I
have
mean,
one.
you're a cheerleader. You're
Yeah,
a
well,
great cheerleader.
well, we are-
Not-
Well, Atomic, it's Atomic Dog. Listen to that song, Atomic
By
Dog.
George,
Yeah,
that's an old school.
Let's,
Yeah,
let's,
go listen to it.
Sing that
Let's-
here.
let's-
I really can't say all that here in the public, but just go look at it's the greatest fraternity, Omega Psi Phi fraternity. There's a lot of barking like dogs, but
Mr. Walker, we'll take their money as long as we don't have to get branded.
yeah, I got a lot of brands. I got about 30 brands on my
You
body.
talking about George Clinton, Atomic Dog?
Yeah, that's it. He's my fraternity brother, George Clinton.
Nuh-uh.
He
Yes,
gets
he is,
carried away
yeah.
with that fraternity. Go ahead, David.
All right, got carried away here.
By the way, that's excellent. That survey's excellent, and like you said, feedback to the staff. We're going to address it. We're going to continue to address opportunities. Look at some stuff for nurses and stuff like that. So, anyway, go ahead.
All right, and that's it. Last thing, Steve Kirschenbaum, interim airport manager, will be here at the February meeting to talk about some of the airport happenings. All the rest of the stuff on my report, we already discussed. That's all I have.
Great.
Okay. Well, that's excellent right there. I like the way you're involved in Tallahassee almost every other day now, and we need it. And I think the personal relationships you can build up, the better off it is for us. That's just it. We have a face over there now that we hadn't had before. So please continue that, please continue. All right.
Wonderful.
Can you get me a George Clinton autograph?
Do what now?
Can you get me a George Clinton autograph?
All right, we have an annual conflict of interest. We need to sign that today, right?
Yeah,
Okay.
I think you skipped, Duffy, I think you could have skipped the line management report and the Weems
Look at this.
Foundation report.
Well, Michael, Mr. Kozar here?
Is he online?
Oh, I'm sorry. I didn't know he was here.
No, Duffy, I don't think he's here. I think he's traveling, but I can give just a quick
Okay.
update.
And
And
I thought yours was all combined. Go ahead.
yeah, I'll just give a quick update. And I want to mention that we have, we have our annual governance retreat that's coming up in the first week in March 2nd, 3rd, and 4th. It is over at the Hilton Sandestin. And at that event, we got, I think what this team here has done, with customer service, compassionate care, and what David just shared, even from an employee standpoint. So you look at the community, you look at what the board has put a lot of focus on in that particular area. You look at the care that's being delivered. You look at the staff that's delivering the care. I mean, these numbers, everything is pulling together nicely for this community as far as from a customer service, compassionate care standpoint. I think when back to the retreat, I have asked and discussed with this team to pull together to share that best practice that you guys have done this past year. And I think it'd be great to share that presentation, or to develop a presentation to be able to share that with all of those that are in attendance, because I think it's, as I said earlier, I think it's important for everybody to hear what you guys have done specifically in that area.
What are those dates?
It's March 2nd, 3rd, and 4th,
Okay.
and it's in Sandestin.
What
And
have we done?
I will try. I graduate in Phoenix March 7th.
oh yeah, congratulations!
Did you get the,
Yes, sir.
you
I
can let
have
them know
it.
you're going if you're
Yes,
going.
sir.
You going to
I
Phoenix,
definitely will
Arizona?
Yes, sir. That's where my school's at.
Okay. But you
the
need to
flag.
let them, that's
I
gonna be
will.
hard for you.
Yeah.
Let me look at it, and
Yeah,
I'll text
I'll-
you, David. Let me
absolutely.
look at it.
Yeah,
So-
they need to book your room and stuff.
Yeah.
like
Yes,
that
sir.
pretty quick.
Yeah, so that day one, we're going to have, we got a lot of best practices to share across the organization.
That's good.
We got a quality repository analytics tool that's rolling out this year that every Alliant hospital will be able to participate in. It'll provide quality metrics, dashboarding, and so forth that can be shared here at the board as well. And that's being rolled out. We've got a team that's going to present that is implementing that, and they'll share their story. I've asked you guys to graciously share your story around customer service, and again, like what you have been focused on. We got a group that's going to be talking about ED, or emergency department optimization, and what they have focused on throughout the year, and how they have really put a from a community perception standpoint, they have really changed the image there culturally.
Where's that at?
It's over in Perry.
Perry?
Taylor County.
We need to listen to that.
They've done a really great job within their emergency department and we got a provider that's going to attend from their providers, and he's going to help share, what they have been able to focus on and do, and they have really increased, again, that community perception of their ER, done a great job.
How long has that ER been there? They've got a brand new one, right?
No, well, yeah, they did some remodeling. Yeah, they remodeling. The hospital's obviously been there, but they did some remodeling
Gotcha.
of that ER. It looks great. It's fantastic. They utilized some of this real capital monies that the state of Florida has allocated. They did an excellent job.
Awesome.
Yeah, so it flows. Yeah, the flow is much
Yeah,
better.
I have to say that anybody that's thinking about it from the board, it's a great week, a couple days that we get together. There's great seminars that you can learn a lot about.
Yeah.
There's people from other hospitals, CEOs, board members, et cetera. So it's a great opportunity to expand your network, get some ideas from other people, and learn a lot about the industry itself. And I found it very helpful, especially when I first came on the board, because I really didn't have that much knowledge about operations of hospitals.
Yeah.
And that definitely helps bring you up to speed.
Yeah.
And everything's paid for by Alliant, basically, so it's not a cost prohibitive situation.
Well, and best practices, and that's what we want to share. Stories that we have seen and heard throughout as well as, what other organizations are doing.
Yeah.
And I think
That's
it's great to
part
see
of it.
that.
Listen to what other people are doing.
Absolutely. And day two, I want to talk about this for just a minute because I think it's very important on this one as well. What we've been able to pull together thus far is we got the Hospital Association president and CEOs of Florida, so Mary Mayhew. We got Dane Howard, she's the president and CEO of the Alabama Hospital Association, and Nancy Galvani is the president and CEO of the Kentucky Hospital Association. Those three association leaders, president CEOs, are going to help day two discuss obviously who they are, what they're doing specifically for their states and the communities and the hospitals that's being serviced by them. But they're going to do 2 panel discussions throughout the day. Those panel discussions of one topic is going to be the Rural Hospital Transformation Program. Each state has done a little bit different. Each state got of the $50 billion they got allotted through the Big Beautiful Bill. Each state got approved applications around 200+ million. And then David touched on a little bit of the dynamics here on how 41 million of that 209 million or 200 million is being allotted to just the Northwest Florida region. Florida broken into 4 regions, and 41 million of it is going towards this region. David touched on that collaborative or that's being pulled together. Of the 8 hospitals, 4 of them are Alliant managed hospitals. So 4 of that 8. So we got a lot of folks that have a lot of high interest in trying to figure out, okay, of those 15 initiatives, what can we do to pull that money down? And we're going to have grant writers and so forth involved. But what they're going to share on that day too is how they're specifically getting involved to help within the states and what they're doing from that standpoint, and share more details around that. The second part of that panel discussion, again involving the same 3, will be focused on rural health or rural hospital resilience programs. And as David just mentioned, the Rural Renaissance Bill that's taken place here in the state of Florida can be very impactful, extremely impactful to this hospital, particularly around Medicaid becoming cost-based reimbursed like Medicare is today. So that would be very impactful, very helpful, increase the reimbursement or the cash opportunity here for the hospital. Yeah, it'd be very helpful here. So
more money, right?
More money. So yeah, absolutely. And so the hospital associations are going to be advocating for this. But again, this will be more of a Q&A format. And the moderator of that day is Chastity Warner, and Chastity is the Florida HFMA president. So I think we've got some high caliber individuals that's going to be sharing a lot of strong information and valuable information, I think, to all of our organizations and what they're doing specifically to help and try to help specifically to our rural facilities.
And David, I just want to mention Mayor Mayhew, is plugged in. Of course, she was the head of ACA, Governor DeSantis appointee. She's the head of the Florida Hospital Association. She's the one that came down that we invited to do the presentation to the county commission at that time. So, she's very plugged in. I think her office is meeting with ACA today to talk about this transformation grant. So she's a friend of Weems, of course, so it'd be good if you can get to meet her individually. But she's the one that pulls me on all these different committees with the FHA as well. So she's very, very good. I think it's going to be good.
And then lastly, just another plug on the day 3 of that. You're going to see a group that, again, another best practice as far as addressing security needs for their hospital, and the approach they took to what I would say develop a security department, and how they approached it, from individual training that they received, specialized training that they received to manage the management of aggressive behaviors, and tactics that they've been trained upon, and they're training their staff. So you had 3 individuals from this organization who went specifically to be certified and trained, and now they're training the staff as well. So they're taking it upon themselves to develop that internal security department, and they're working in collaboration with the local police department as well. So it's a good, I think, a best practice that other organizations should consider or take a look at. I want them to share their story as well, so and give more insight around that. So.
Okay. All right.
I have one question, Mr. Walker. How often does that group of 8 or 9 hospitals meet?
Well, we just started meeting and at least once, we'll start meeting probably once a month, either a little bit, either bi-weekly or once a month. But we met, they started in December, I believe, and then we had a meeting, the beginning of January.
Yeah, there's been 4 meetings so far. I mean, so it's going to pick up a lot more momentum. David mentioned ACA was submitting it was going to be submitted, I think it was yesterday, right? And it got postponed. But once I guess that gets more known with what we're going to be able to seek after that funding, I mean, it's going to pick up
It's gonna
rapidly.
take off.
Who is driving that process? I mean, is there one individual, or are the 9 individuals? I mean, somebody's got to set
Sure. Well,
goals,
President.
and what we're going to do. Is that paper been established yet?
Yeah, if you want to chime in, I can chime in on that. Either one.
Yeah, go ahead, Dave.
Well, no, to answer your question, yeah, we are helping facilitate this through the leadership of the CEOs of each of those hospitals, ensuring that, one, you know, and I'll mention this too, there will be a body that is not going to be a specific hospital, but a body that each hospital will participate and fall under that will help facilitate this. That is in the legal development currently, as far as what that body will look like and who is administering that. There will, because that body and these hospitals will have to make the decision, because there will be grant writers. So rather than 8 different hospitals going after
Right.
these monies, it is recommended and highly recommended that you pull together this cohort and this collaboration, and you work through that legal channel. That way, that monies can go down to the hospitals. That legal channel is helping to pull those funds down. The hospitals, though, will have to contribute to this in some way, right? Because there's going to be grant writers involved, or a grant writing company involved, and we already are speaking with that company. The company's done an extremely great job in the state of Florida, Florida-based company, and they did a fantastic job at Calhoun Liberty and helping secure monies for that hospital. They've done a fantastic job over in Taylor County, helping secure monies for that hospital after the 3 hurricanes that hit there within a 13-month window. So they've done a lot of great work, I think, throughout the state, particularly across the
And
northwest region.
there's another individual in charge, or a group of individuals in charge of that group that's going to interface with
That's
the
correct.
9 CEOs?
That's correct. That is
Okay.
correct.
So they're basically the drivers, this other company. Because the 9 CEOs will meet and set policy or guidelines, but somebody's got to do the work.
That's right. That's right. The grant writers, yeah, that is a company. It's Ovid Solutions. I mean, I'm not mentioning the name. And that is a company, yes.
So, well, maybe you can bring back
Yeah,
next
absolutely.
time,
Oh, yeah,
tell us how
absolutely.
that feeds down into
Absolutely.
Weems and what we have to do to
Ab-
ensure that we're getting our fair share of the money.
Oh, absolutely. I
Yeah.
mean, absolutely. And that's why we gotta ensure, I mean, there's 41 million that's getting allotted to this northwest region. And again, there's 15 initiatives. Each of those initiatives have caps as well of monies. The hospitals have, as David said earlier, have already been polled. What is the top initiatives for the hospitals, right? That way we can collectively say, okay, these are the top 3, 4, 5 initiatives collectively. That's the monies we're gonna go after and seek. These other initiatives that are out there, it may not be a high priority for any of these.
Especially for year one, because what you'll have, you know, of course, Weems will be at the table. You know, that's the bottom line. Every hospital, the rural hospitals are at the table. And so the money, the rural hospitals will submit that grant, okay? You know, we'll have to submit that grant, and then that money comes down to us. Now, we may have to identify a hospital that would handle the funding part of it, you know, because it's like Weems, we don't have the infrastructure. So you look at, you know, maybe either Northwest Florida or Jackson Hospital.
It'd be a separate.
This is the pot of money that's the 48 million, or-
Yeah,
right?
yeah.
Okay.
And so it'd be like, okay, we will identify, the 8 hospitals will identify at least one hospital per se to handle the financial aspect of the grant. You know, they will have the infrastructure there, instead of having another entity to handle that and push back down to the
Well,
hospital.
why don't you just give us a presentation next time how this works?
Yeah.
I don't want to tie it up anymore. but
Yeah.
I think that this is personally is the driving force that's going to get the money down to the county.
Absolutely. Well, I mean, the collaborative partners that are involved in this, I mean, you do have hospitals, right? That is one collaborative partner. You got
all these other little
you got
guys
federally
around, but they're
qualified
going to have
health
to.
centers, behavioral health centers, local health departments, EMS agencies, community-based organizations, education organizations.
How many do we have in Franklin County that are going to do that? Do we even know?
Well, we don't know. I'm thinking the federal qualified health centers, I'm sure they probably gonna have their own collaborative with their people, per se.
We can't control that.
You know, you can't, in the Department of Health, you know, they may.
That's fine.
They
They
may
need
want
it.
to collaborate with us, but they may collaborate with their other health departments, you know, statewide.
All right, anything else?
We're good, yeah.
David?
No,
David.
no, that's all I had, basically. Yeah.
Okay, anything else? Okay. Let's see, we have if you look in your packet, the annual conflict.
Colleen,
Oh, I'm sorry. I'm off today. I'm sorry. Thank y'all.
It's okay.
I'm off today.
This is very
John, you
reminiscent of
fill
when
my head
I
with so
worked
much
full-time,
stuff, I can't
and I would have to
absorb
go
it
at the
all.
very end and speed talk through everything, so I'll just do a couple highlight points, and I have some handouts for y'all. I think this theme has come up, dovetailing from the finance discussion, and real robust discussion around perception of the hospital. When I stepped into this role 3 years ago, in 2023, we definitely were hearing anecdotally two themes that continue to plague us in the efforts of the foundation to garner community support. That's trust in the care that's received here, and then awareness of what care is available here. However, we're already seeing some trends at the end of last year and early in this year already that the sort of focus has shifted. The trust is increasing, and that's based on all the great work that everybody here does. People are asking, when we engage with them, to say, hey, would you like to get involved as a volunteer or a sponsor or a donor? What we're hearing is, yeah, I'd love to know more and be able to more articulate better what services, what care is available to me and my family members, loved ones through Weems. So basically, we as the foundation have identified a few priorities that are well aligned, obviously, with the priorities for the hospital. But key to our success this year will be raising awareness of really what is available to people at Weems, right? So I won't go into the details now because we're at the end of our meeting and I stand between you and your lunch probably. However, I'll give you a quick update on how we did in 25. And then just share with you what some of our priorities are. So in 25, we learned, of course, that through some grassroots efforts and continued driving positive interaction and traction with the community, that our engagement from the community and people who are interested in sponsoring and donating to our cause, that increased. We did put all of our focus last year on our single event in November, so the one fundraising event. And while it was successful in garnering community engagement and interest to lean in and join us in our efforts, financially, we're beyond breaking even, so we're covering our costs, but that cannot be our sole form of fundraising. So we're going to double down this year. The opportunities obviously are for us to expand our outreach, which we've already started doing, expanding our volunteerism. We're looking for more volunteers. We're looking for more people to join our team. And we're already headed in a good direction there. We've added 3 people to our team just this month. We are looking across the Franklin County, identify more fruitful and mutually beneficial partnerships within Franklin County itself. Really key to our success is in this perception area, ensuring more broad scale awareness, as I said, and trust in what we provide. So I've already started a conversation with Mr. Walker and with Christy Terry about things we should and could be doing to ensure that we're out there. When the community is looking for information, they know where to go, and the information is accurate. Someone mentioned just earlier today, like a bio on Dr. Conrad. People are asking all the time, well, who's going to provide me care when I go there? Or, can I trust the services? So we need to continue to battle that, and I think we're headed in a good direction. And then, as I said, doubling down on fundraising. In addition to the fall event, we've already started a hardcore donor drive, and happy to report that we already have one business that's sent in a donation, and we have 2 private donors who have, one is committed to quarterly donations.
Oh, wow.
And
That's
one,
huge.
I haven't confirmed the amount yet, but by the end of this quarter, they'll be sending a donation. I will comment on, Mr. Walker shared with you that someone walked into the hospital and said, hey, I have a check for $10,000, and now they want to bring another $5,000. That, I believe, is based on the work that we're all doing together, right? He's, as I understand, he's someone who lives part-time here and part-time in Atlanta or something. Okay, so the awareness and the interest in helping us propel, the level of care, the perception here, there are people who are starting to lean in. So that's good.
Yes,
That's
it
good.
is.
So then just our priorities for this year, and these have been published broadly and have been generating a lot of good questions, comments, and I said donations and volunteer people raising their hand. That's starting to happen, and we're just in January, so we're heading in a good direction. First and foremost, using Mr. Walker's language, comfort and compassionate care, we're supporting our growing clinics, as was mentioned earlier, based on our modest but successful work last year financially. We are going to be making a donation to help support improvement at the clinic, so adding to the beds. So we're working closely with Courtney and Mr. Walker and Craig on that. There are other things that we're going to be doing, such as supporting National Hospitals Week, just again looking for ways to elevate awareness of what's happening, what services are available. And then another big priority for us, what we're couching in the theme of stronger bone, stronger community, bringing the DEXA screening home. Obviously, that's a big ticket item. In order to garner the interest and support by those folks who really could help us financially support that goal, we're proposing that we push out education all year long about the importance of bone health, so that when we get to National Osteoporosis Month in November, people are interested and they're like, how can I contribute? So we're not just going to push out a request, please write a check. We're going to be educating people and making sure that information is available to them. Again, all value adds through the support of, with Christy Terry and the team over there. And then finally, as I mentioned, just increasing public perception and awareness of what we provide. So we, the foundation, have mapped out a communication plan that we plan to work with folks like Susie and other folks to make sure that the information that we're pushing out is consistent and just across the calendar year. So we're not just popping up once a year in November, hey, join our foundation event. And I think that's really it. Any questions?
Only one thing, I think that a lot of the public awareness is coming off of that, our meetings being broadcast. Okay, and I think that if the foundation were to have a presentation at each time of where our progress is, and it got out to the public, because a lot of people are starting to pick up on these.
Okay.
I think that would help a lot also, and that's where the trust is going to come from.
Sure. It's also people sharing their own experiences, right? So y'all who sit up there on the board, any of us who are seeking care or have interactions with people, our ability to champion what's happening there is important too. So, we have a plan to hopefully push out some patient stories, meet the staff, all of that. But, people trust information from their peers more than they do the media, so we're going to capitalize on that this year.
With regard to, you said the emphasis was going to be your bone care, your
bone care, bone health, yes.
Bone health,
yes.
Okay. Mr. Walker told me that the new CT machine, we can get an add-on to it, possibly?
We found out that
this is good.
the CT machine and I hadn't talked to Colleen about this yet, though.
Okay.
Because it's.
Surprise.
Blindside.
No,
No, this is real
we just
good.
found out.
We just got the information.
We just got
Before
them.
yesterday.
I told Brian, my radiology manager, to see what we can up like the CT machine we have, we can upgrade on different things. You know, so I said, hey, you know, find out if we can do colonoscopies on that, you know, or DEXA and cardiac screenings as well. And so he came back and said, yeah, you know, the machine can get upgraded with that. Of course, it's a $28,000 upgrade fee for that. And so that may be something as, you know, as we begin to look at, you know, the DEXA bone screenings, you know, do we get a separate total DEXA machine? Can we upgrade that machine for $28,000? You know, so that's something that we.
Interesting.
To do the same thing.
Money well spent.
Yeah, then we
Money
found
well
out.
spent.
Yeah, so it's different things we can do. It can do DEXA. It also can do colonoscopies, I heard. It can do the cardiac screenings, which the cardiac screenings part would be very important as well.
Like calcium cardiac.
Yeah. So that's some of the things that the machine can do. Now, we don't have the machine yet, though.
Okay, well, that's something that we're trying to do,
Yeah.
okay.
So we could do those things, and then Main Street can bring in a different specialist for this,
Possibly.
other than just on college?
No,
Main Street
they're
doesn't cost.
specifically on, but it might correlate, some of that testing might correlate with their services. Do you see what I mean? I mean, some cancer patients might need DEXA.
Yeah, for example,
Right. Right, exactly. Exactly.
and then if you get a
So those two fly
mammogram,
together.
you know, if you come for a mammogram, sometimes they send you for a DEXA as
Right.
well.
Right.
You know, so you probably can do all that at one.
My wife's been doing that. Go ahead.
Well, wouldn't it be great if you could do it
Tallahassee.
here?
She would come here if she could get both of them.
Yeah,
Right.
at the same time.
Right.
Of course.
So those are some things that, and Colleen has doing a wonderful job, really, with this, and with the new handouts she's gonna show you all, that we all can be speaking the same words, and when people asking what we're doing and what they're doing, we can have that information.
That's wonderful.
Thank
Thank you.
Yeah, I'll
You
just
work-
leave, can I give them to you and you
Yeah.
can pass them around? So what's on here, just reiteration of the two priorities, and then there's information about donation, a donor box. There's a QR code, there's a place people can go, and then there's information about levels of giving associated with the event in the fall. And if you have questions, send me an email.
Like a school teacher.
Thank you, sir.
Thank you, Colleen.
Thank
Thank
you.
you.
Thank you very much.
All right, moving down. Almost, Courtney. Courtney, we got you.
Wait a minute, we're not through yet.
Hang in there.
Now, we got new business. The annual conflicts of interest attestation. I think we need to sign that, don't we?
Yes.
Okay. Sure you don't have. It's in the back of this. Also, the annual review of board bylaws.
And just make sure you all read your bylaws, because the bylaws really, you know, gives you, the board, authority, you know, on your oversight of the hospital. And so, you are the governing board, you are the board that the county commission has appointed
Right.
to manage the hospital. And so the bylaws give you that authority on that.
Okay. So the board needs to review them and I'll sign off on them, correct?
Yeah. It's,
Advisory.
Have we changed anything?
no, we ain't changing anything. It's an advisory board. However, you know, from the legal standpoint, the governing board has the authority of the hospital. And so that's why the county commission appointed you all
Yeah,
for
sure.
that. Although John like to say advisory, which we are advisory board, but you
We are.
You have authority.
That's fine. Okay. Okay, we got the CEO annual evaluation. We're a little lagging with that. You'll be getting an email with an evaluation, okay? 1 through 5 or whatever it is right there. Now, will they ever be able to fill it out online and send it back, or they need to bring it here? Okay.
Yeah, it can be filled out online.
Okay, fill it out online, and,
Well, it'll be, I mean, it can come as a, you know, a Word document, PDF document, however you
Okay.
need it, but, you know, you'll fill it out that way and email it back.
okay.
Yeah.
Okay. And I think Mr. Kozar will do one too. He'll be, look at it too, of course. So that'll be coming, and if you do that for the next meeting, is that gonna come in the next week or so to the board
It
members?
should, yeah, we can push that out today or tomorrow.
Okay. All
Yeah,
right.
it's ready to go.
Is it anonymous?
It's anonymous, yes.
No, it's not anonymous.
Well, it's anonymous when we roll it up and present, because what we
Yeah,
will
if we
do
roll
will
it
come
up,
into
yeah,
the
but
whole.
you
Yes.
stand, no, I don't like nothing anonymous. But anyway,
Well, I won't know what you're saying too. I really won't know.
well, this, I tell you what, though,
God, good it to me.
so we'll be doing that. Also, look at compensation for CEO. I think we're lagging behind with that. We need to look, see what other folks are making, comparatively speaking. Not the top, not the middle, somewhere around the middle. We need to look at the composition section. One more thing I got. This is a big one. This is me again talking. I would like, for every board member, to jot down one thing you would like to see us accomplish in the next year. Something that's possible, we know could get done. One thing, if you want this one thing done, one issue. Well, okay, one issue. And let's get in our meeting, let's decide what that one issue will be between all 5 of us, or 6 of us, and put the, what's the new term, laser focus on getting it accomplished. If we all get on it, and now and let's discuss this, get all behind it, but one issue. Maybe we'll get to the second one. We may be prioritized. Don't get mad if you lose what you want done, but I think we can discuss that. What do y'all think about that?
Sounds
Bill?
Yeah.
Sounds
Think
good.
it'll be okay? Let's don't go pie in the sky and make $5 million, something like that. Let's get one issue, no matter how trivial it might be.
Is it going to be anonymous?
Yeah, you make it up.
But it is like projects like the pharmacy, right?
Yeah,
exactly.
One project,
Yeah.
Well,
I
Chair-
would say a
Chairman,
new
it's-
hospital, but I don't think we can accomplish that in a year.
Well, Chairman, if I can
That's
add.
going,
Yeah.
that's going to need the county board approval, but that's something that, if we don't get approved, don't get approved, yeah.
Well, Chairman, if I can make I'm glad you just mentioned that, because I told David, it just prompted me to bring this up as well. What we plan, and I want the board to be thinking about the timing of this, but we do plan this year, and preferably, in the spring period, maybe early summer latest, because we want to do it before the budgetary season starts, but we want to do a strategic planning session.
Okay.
And we did this a few years back. I think those that were on the board may recall we did it. I think we hosted it over in the Gibson. But the plan there would be, again, we have an individual from our team, Belinda Minch, who does a wonderful job for those that have met her before. She pulls market information, out-migration information, meaning claims data, where patients are going to seek care. She talks to community leaders, talks to the board, obviously, the county commissioners, providers, anyone else that we feel and has their input and weigh in on what they see for the future of healthcare here for this community. And again, that planning session, involves what direction we want to go, what do we want to be focused on. And I think your comment to the board members about what one item, that plays well into teeing up this strategic session. Now, what I would ask, though, the board is when would we want to have that performed or that presented? Because there's work that goes into it, right? Upfront work and so forth. There's surveys that go out. There's interviews that go out, or interviews that get conducted and so forth. So just be thinking about that, about what time frame. We want to do it early summer, late spring. What's going to work for everybody's calendars. And
It would be right here somewhere too,
It would be
right?
here. Yeah, it's all here. Yeah, all here locally. Yeah.
Oh, okay.
Yeah.
When?
Summer.
Yep.
Summer? Midsummer?
3 months probably before you start any budgetary.
That's definitely the idea.
What about midsummer? Is that too late? Or you want to do it a little earlier?
Yeah, midsummer can work. Early summer would probably work ideally best.
June?
June.
Okay,
would
good.
probably be a
Let's do
good
it.
time,
Fine.
honestly. Yep.
June would be fine.
So
Good.
I'll tentatively write down June, then we'll back into what that timeline and calendar looks like, and I'll have that ready to share with you guys as
Okay.
well.
Okay, be ready to say what you want done now. I think I think we'll come up with some stuff, and I just found out if you take one thing and concentrate on it hard enough, it gets done. Generally.
Well, that have to be, you know, whatever we decide of doing a strategic plan, then it have to be budgeted, you know, with the new budget year too.
Yeah.
You know, so, you know.
Okay, anything else?
No.
Meeting adjourned now.